Good morning. We're going to go ahead and get started. I'm excited that you're all here this morning. On behalf of the Alabama Beverage Control Board, our 880 employees, the Planning Committee, all our partners, welcome to the 2023 Alabama Substance Abuse Youth Summit. Please know how appreciative we are that you're here with us for our third Alabama SAYS Conference. What we do today is just another step towards what we hope will be many larger conversations, strategy sessions about how we can finally end underage drinking and substance abuse. Each of you here today is working extremely hard with the limited resources you have. Please take a moment to look around this room. Look at the list of agencies and organizations that are represented here this morning. Now just think about what we can accomplish when we all lock arms, march forward together. Hopefully you've all heard of our anti-underage drinking awareness education program. Underage, under arrest. I'm proud to say that tomorrow the ABC board will present its 150th, 151st, and 152nd programs for this school year. We've conducted more than 600 programs since we began in 2013 and have reached approximately 200,000 Alabama middle, junior, senior high school students. But we can do more. We can all do more. Our goal for this summit is to bring together child advocates and service providers from all over Alabama, to hear from recognized experts from around our state and country. Afterwards, we can collaborate, share ideas, and forge a collective, comprehensive strategy. We hope you find that Alabama Substance Abuse Youth Summit to be educational and helpful. More importantly, we hope you use the materials and ideas shared here to re-energize, to focus, to strengthen your current efforts, and to find ways we can develop new statewide approach to ending underage drinking and substance abuse. As you can see, the summit is being attended by many knowledgeable professionals and experienced service providers who are deeply committed and tireless advocates for our youth. Take time to meet and make new friends, pick their brains, and share information. That's what the summit is all about. I hope you will take time to review your conference booklet. In it, you will find the schedule of events, bios of our speakers, a list of our partners, and folks who help plan the conference. I would be remiss if I didn't take a moment to highlight one of our most important partners, the National Alcohol Beverage Control Association. NABCA represents and provides research and other helpful information to the 17 states, including Alabama, that directly control the distribution and sale of beverage alcohol. It also offers its members access to a competitive grant program. By the way, one of those grants is allowing us to provide this summit today. We can't thank NABCA enough for their help. Also in your material, you will find a post-conference survey that we kindly ask that you fill out and leave with us at the end of the day so that we can get a jump start on planning next year's summit. Again, welcome to the Alabama Substance Abuse Youth Summit. I'm glad to turn the program over now to Dean Argo, our Manager of Government Relations and Communications, for further instructions. And thank you again and enjoy the conference.
Thank you, sir. Appreciate it very much. Good morning. One thing that Mr. Winkler didn't tell you is that he's only been on the job for about 2.5 weeks. He started with us on April 1st, and we are so glad to have him with us. He comes from the Revenue Department, where he spent a career, and now he is going to help lead us for the next foreseeable future. Hopefully, he'll be here with us for a long time. I want to thank everybody for being here again. Most of you are what I would consider to be experienced summiters. You've been with us for all our last two, and then of course today. Those of you that were here with us last year, you'll remember that we were at Church of the Highlands in Montgomery, and that auditorium was so large, it didn't look like anybody was there. But in fact, today, we only have about 50 more people with us this morning that were with us last year. So you look at this room and it's absolutely packed, which is really good for me because part of my job is to take photographs, and it's a lot easier to take photographs of people when they're together than they are when they're spread out throughout the auditorium. So I appreciate everybody coming in this morning, grabbing a chair, and hopefully you're getting to meet some people you didn't know before, forging those new relationships, new friendships, some collaborations. So we really appreciate you being here this morning. I promised in my email to you that we had some exciting news, which I'm going to share with you in just a moment. But I want to make sure that everybody knows how we're going to proceed this morning. We have 3 speakers this morning, then we have lunch, and then of course we have 3 speakers in the afternoon. And we are going to make sure that in between some of those speakers that we return our thanks to you by making sure that we draw for door prizes. I want to thank my folks at Laurel Oaks. They've provided us a couple of extra door prizes, and Bradford Services has also provided a door prize. So we'll have a few more things to give out this afternoon. We appreciate the donations, the contributions, and the support of Alabama Says. Hopefully when you came in, you saw the restrooms. They're right outside the door here on either side of the registration table. Please feel free to make use of those as we go out throughout the day. Lunch will be here at 12:15. So we'll make sure that you're out of here on time to make sure you get lunch. Chappie's here in Prattville is supplying our lunch today. So I hope that you will enjoy that wonderful meal. And the most exciting news that I have for you this morning is that how many of you were here last year? Awesome. You will know, those of you that were not here last year, that our grand door prize last year was a 55-inch color television. We're going to have another one of those today. You also know, and Ms. Rashawn, I'm so sorry to say this, in order to win a TV, you must be here when we call your name. But I promised Ms. Rashawn that if I did draw her name, that we'd work something out. The most exciting news is this year we have 2 TVs. Our good friends at Booster Digital in Tuscaloosa, a big supporter of underage under arrest, and the Alabama ABC Board is providing 2 TVs this year. Those will be our 2 grand prizes. We'll have some $100 gift cards and some $50 gift cards. So I promise you, you want to be here for the door prizes. I also want to just let you know again how important this summit is. If you've come today and you've enjoyed your coffee and your donut, and you enjoy the speakers, and you enjoy your lunch, and you either win a door prize or not, and then you leave, if you don't take advantage of the information, the knowledge, and the experience in this room, you've wasted your day. Because I promise you, I know most of you in this room either by your name, by your face, or your reputation. So I appreciate you being here, but I'm counting on you to take the information that you learn, share it with those that couldn't be here, and let's really start working together to protect our kids. That really is our aim, our goal, our focus today is to protect our children. So I want to make sure that we do that. I can't think of a better way to start off our program this morning than with our state health officer. Dr. Harris, I've known for quite a while, and I invited him last year, but his schedule, as you can imagine, coming out of COVID was so hectic he was unable to be here. But I saw him at lunch just several months ago, and I said, hey, Dr. Harris, you remember you promised that you would come to the next summit. And he said, I'll be there. And he's here this morning. So let me give you a brief introduction for our State Health Officer, Dr. Scott Harris. Dr. Harris was appointed Acting State Health Officer for the Alabama Department of Public Health in September of 2017 and formally designated as Alabama's 12th State Health Officer in February of 2018. He's a graduate of Harding University in Arkansas. He attended medical school at the University of Alabama at Birmingham, their School of Medicine, and he served an internal medicine internship and residency at Caraway Methodist Medical Center in Birmingham before returning to UAB to complete a fellowship in adult infectious diseases. He earned his MPH from the UAB School of Public Health. He is a tireless volunteer. He is a tireless volunteer physician, and he served on many international medical missions to Central America, South America, and Africa. He is a good friend. He is going to have some great information for you this morning. So please welcome to the stage our State Health Officer, Dr. Scott Harris.
It's really hard to tell Dean no, first of all. Really glad to be here. I'm really sorry I couldn't be here last year, but it's just terrific to be here with you. I just appreciate you all being here so much. It's going to be a terrific day. We've got some great things that are scheduled. I'm very excited about it. I know that you're going to hear about it. Many interesting things, and as Dean said, please take that information and share it with somebody. Don't just hold on to it, but please take it and give it to somebody else. But thanks, Dean, for having me. Mr. Winkler, thank you so much. I do want to find Nancy Bishop, who's our state pharmacist in the back. She's responsible for putting this together, and I just have to thank her so much for taking the time to do that. I'm very grateful. So because we're public health, we got lots of numbers for you. We got lots of data. We spend a lot of time putting these things together and trying to sort through them and figure out what we can do with it. If you happen to come to the opioid summit at Fraser a couple of months ago, you've seen a little bit of this, but there's a lot of new and interesting information. And really what we want to do is just show you kind of sort of the scope and the breadth of what we see the issues are in Alabama, and you'll notice kind of what we have to show you, and you'll probably notice what we don't have to show you. You know, we don't have perfect information. There are a lot of pools of data out there that we just can't get our hands around, or we haven't figured out how to collect them, or we're still trying to figure out ways to learn about them. But what I really hope is that you'll notice what we have, and for those of you that are involved in this work, like most of you, most of you are, please see what we have to share with you, okay? We have lots of good information. It comes from just a few discrete sources that we have access to in public health. It's only one part of the many types of information you can find from various government agencies and nonprofits and other folks, academic centers who do this type of work. But I really want you to see what we have in public health so that you know where to come get the information you need when you're trying to get the information you need. So we're going to get into this in just a minute. It's pretty data heavy, but I really want to start just sort of talking about sort of the overall current situation before we get into the details. The situation in Alabama in terms of public health in many ways is not good. You know, Alabamians are dying now, and Alabamians are dying at a pace that we haven't ever really seen. Certainly I've never seen in my career, and a lot of this is going to be reflected in numbers around substance misuse. And of course, a lot of it we can attribute to the pandemic, but there are lots of other reasons that people are dying in a way that we've just never seen before. You know, we've spent the last 3 years trying to come out of the pandemic or working on the pandemic, and just because of, you know, bandwidth, that meant we had 3 years of not doing all the things that we normally do in public health. You know, there were plenty of things that we ignored, not because we wanted to, but because we really had no choice. I know you remember before the pandemic, we were doing a lot of great work around substance use, including opioids. And there were, you know, many of us who were working with educating and providers. We were doing tremendous work and sort of helping people understand what resources are available to them, actually helping people who need help themselves, working with law enforcement and how to work with people who come into that sphere, but have an issue with addiction and so on. We did all those types of things, and then, in March of 2020, the whole world kind of changed, and we weren't paying attention to that for a long time, and you'll see the reflection there. We did begin to see overdoses going up, ER visits, and for overdoses, deaths, and so on. So we're going to see kind of where all that went. That's not the only thing we weren't paying attention to. There are lots of things that we weren't doing very well. Immunizations for kids are about as bad as they have ever been, certainly in a couple of generations. And I don't mean specifically COVID vaccine, but all vaccines. Kids just aren't being vaccinated right now for lots of reasons. Some of it just has to do with the disruption of medical care during the pandemic. Maybe providers weren't doing those well kid checks, or kids weren't going to school physically. They were in virtual school and they didn't need their immunization certificate for a while. In many cases, there's misinformation out there about vaccination, and we see folks at the health department who have all of their 5 and 6 and 7-year-olds fully vaccinated who want an exemption for their newborns, for any types of vaccine. So there's trends there that are really worrisome to us. We've seen plummeting numbers of women getting pap smears and mammograms. That, again, was disrupted during the pandemic. People put off a lot of that, what they perceive as elective care or not urgent care. And we know what happens if you stop screening for cancer for a few years. You're going to get more cancer. That's a debt that's got to be paid in the future, right? That's a disruption that we're going to have. And so those are just a couple of examples in addition to the ones around substance use. But I want to show you, if this will click, let's see. Hey, it worked. That's good. So this is this. Oh, there's a delay. Oh, okay. Okay, maybe if that doesn't change, we'll be okay. What I want you to see is maybe a slide that you can't make out so well because it's maybe far away from you. But what you have there are sort of two lines there, and the darker colored line is just showing the number of deaths from COVID that we've seen. But the lighter colored line, the reddish colored line, is actually showing what we are calling excess deaths, okay? And excess deaths are those deaths that are occurring in our state or in our country that are more than we would expect, right? We've got, decades and decades of information about how many people die each year, and we kind of know, based on how many people are born and what our life expectancy should be, about how many deaths we can predict. And we have more people dying than we would expect to have, right? And COVID explains a lot of that. Over 1 million Americans died with COVID. More than 21,000 people in Alabama have died from COVID so far. We still have, 200 to 250 people a day in this country dying from COVID. We have 3 or 4 people a day in Alabama dying from COVID. So that still continues on now. But that doesn't explain all of these excess deaths. There are more deaths than we would predict. One of the, most mean-spirited attacks we heard during COVID was that COVID's not real. These are old, sick people who were going to die anyway, and you're just attributing it to COVID. Well, actually, that's not true. We lost a lot of people who were older, who had chronic health problems to COVID. And above and beyond that, on top of that, we see increased numbers of people dying for other reasons as well. So another slide that wow, that just goes so fast. Another slide that I'm sorry is not going to show up very well, but I'll just interpret this for you. In terms of life expectancy in the world, we're not doing a great job in this country, okay? Our life expectancy had begun to decline for a couple of years before the pandemic even started, and that was primarily due to increased numbers of deaths in middle-aged men and older men, in many cases associated with what we call diseases of despair, related to substance use, including alcohol, suicide, and self-harm. There were many different reasons for that, but life expectancy was declining before the pandemic even began in this country, and now has continued to decline since the pandemic began. What this slide would show you, if you were able to see it, is that we sort of rank up there with sort of Central and Eastern Europe in terms of how our life expectancy is. Most of the rich, educated countries of the world, of which we want to belong to, have managed to turn around their declines in life expectancy over the last year or the last year and a half. Again, some of that's due to COVID. In terms of getting people vaccinated against COVID, we're about the 66th best country in the world, okay? So there's about 65 countries that did a better job of vaccinating people than we did. And these folks have come out of the pandemic in a much better place than we have. But there are other reasons as well that we're ranked with the likes of, Bulgaria and Romania in terms of our life expectancy. Let's see if it advances. Wow, it just goes on its own. It's kind of mindless. So this is a graph that sort of shows you life expectancy in our country right now. The blue and darker blue shows longer lifespans. The sort of lighter red or dark red shows shorter lifespans, shorter life expectancy. Life expectancy in this part of the country is about as bad as it gets in the United States, okay? People just don't live long in our part of the country, and there are a lot of reasons for that. We spend time in public health trying to think about how do we predict how long people are going to live, what's the arc of their life going to be with regards to health, what determines how long you live. What determines it is this category of things we call determinants, right? And there are all kinds of determinants that will predict how long you're going to live. Some of those are in your control. There's personal behavior determinants, right? Do you choose to smoke or not? Do you, care about eating healthy foods or not? Do you exercise? Do you drive really fast without a seatbelt? All of those are personal determinants that can determine how long you live. There's other kind of determinants that are in our society about do you live in a place that has a hospital nearby? Do you have, physicians available? Do you actually have, medical literacy enough to understand how to seek care, when you need to do that? That certainly matters too. They're genetic determinants, are you born with sickle cell disease? Are you born with cystic fibrosis? And those are all things that determine your lifespan, and some of those you can do something about, and a lot of those you can't. But the biggest category, the thing that you hear public health talking about all the time, are what we call social determinants, right? And the social determinants are those situations that you're born into that really have a profound effect on how long you live and how healthy you are, and maybe you can't do anything about them. The social determinants that matter the most actually are race and income and education, but particularly your parents' education, the neighborhood in which you live. All those things are actually more powerful predictors of how long you're going to live and how healthy you're going to be, believe it or not, than personal choice. Now, we all agree personal choice is a big deal. We want people to make good decisions because we can actually control that factor. But we can make better predictions about people's life expectancy and health just based on those other factors. For infant mortality in our state, for babies born today in Alabama, how do we make a prediction about how long they're going to live or if they're going to survive that first year? The most powerful predictor of infant mortality is what's your zip code and how far did your mom go in school, okay? If we know those factors, we can make a better prediction of infant mortality than did your mom get prenatal care? Is there an OBGYN nearby? Did you have a delivering hospital nearby? Even do you have insurance? Again, all those are really important factors, but they're not as important as what's your zip code, okay? We have reached the point where the state you live in is just another social determinant of health, okay? We live in Alabama. We're not as likely on average to live as long as other people, and that's a really big problem, okay? That's a really big deal that takes a lot of different folks working from a lot of different areas to try to get a handle on. We've got a long way to go to kind of sort all that out. Let's try next slide. Okay. Again, one more slide that may be challenging to see, but I think you can see everything you need to know here. Never before in the history of the state of Alabama have we had more deaths in a given year than births. Okay, it's never happened before, and we have information going back to the 18th century. This slide I think starts in 1910 because that's all I could fit on the slide. But you can see these two lines, and they kind of track each other. The top line for most of the slide there in red is how many births we average per year in Alabama. The lower line, the darker colored line, is how many deaths that we average per year in Alabama. And you can see, you can go back to, you see the giant post-World War II baby boom that happened, right? You can go back and see the dip when the 1918, 1919 Spanish flu pandemic hit right after World War I. We've always had more deaths than births. Now, those lines are converging a little bit because Alabama's a graying state. We're a state that's a little older on average. But now for the past 2 years, and it's going to turn out to be the last 3 years, we've had more deaths than births in our state, and actually by a lot. In 2020, when the pandemic started, about 7,000 more deaths than births. 2021, more than 10,000 deaths more than 10,000 more. And then 2022 numbers, we're still adding those up, but it'll be 6,000 or 7,000 more deaths than births. So we're getting smaller, we're shrinking, and that has never happened before in the history of our state. So I'm gonna, sorry, one more. So leading causes of death, again, I'm sorry that this doesn't show very well, but heart disease and cancer are always right up there. For the past 3 years, COVID has been a top 2 or 3 or 4 cause of death, depending on how you total those, throughout the country, and you know, may well even be that this year, or is going to be certainly in the top 7 or 8. The fourth one on this slide is actually unintentional injuries, and you can imagine what a lot of those are, right? That some of those are traffic accidents, or some of those are unintentional firearm things. But this is where we put accidental overdoses as well. When we're classifying these deaths, we try to understand, you know, there are actually intentional overdoses as well, right? And they don't fall into this category. But these unintentional injuries, which includes substance misuse, accidentally, is now the fourth leading cause of death in our country, all those factors being considered. So that sort of brings us to, you know, how did we get to this point? What's actually going on here? These are a bunch of headlines, again, that you may not be able to see very well, but I bet these stories are familiar to you. These all came from the last year or so, and you can see doctors concerned about adolescent overdoses. Jefferson County deputy revives infant from drug overdose. Father arrested after toddler overdoses on heroin. Death of Alabama student linked to fentanyl. Toddler finds dollar bill stuffed with fentanyl in Alabama parking lot. Fentanyl kills teenager. These are the stories that we're seeing, and these are stories that are unfortunately increasing in numbers, and I think you know this, right? And that's why we're all here today, because these are the things that we're grappling with in our community. So let's try to take a look at actually numbers. This is I promise that's just doing it on its own. It's amazing. Okay. This is a SAMHSA survey from 2021. SAMHSA, you know, I think most of you know, is sort of the agency within HHS that primarily is responsible for mental health in this country. And you can see that in the past year, the survey showed about 22% of people aged 12 and older reported using some type of illicit drug. But almost 4 million of those were teens and adolescents, okay, using illicit drugs. These are illicit drugs. The next thing below that, if you can see that, shows prescription pain drug misuse. And there were somewhere around 8.7 million people who reported using prescription pain drugs, presumably obtained legally, at least at some point, in that particular year. So the scope of this is really quite amazing. You can also, I don't know, not sure what's happening. As you all probably know, most new users of cigarettes and alcohol and marijuana are going to be teens and young adults, right? That's the age group in which we see people that aren't quite as risk averse. You know, you get a little bit more risk averse as you get older in most cases. These are folks that are susceptible to peer pressure, like actually we are at every age, but certainly that group is not any better in that way. These are folks that are interested in experimenting with things, right? Inhalant use in particular, paint thinner and glue and those kind of things are the highest usage is found in that teenager group, in some cases maybe because they don't have access to other things, but clearly that's the age group that's using that. So in the last year, about 1 out of 8 teenagers use some kind of illicit substance. And you can see in Alabama, around 7% of people 7% of 12 to 17-year-olds use something in the last month, okay? So just under 10% of kids, high school kids, have used something within the last month. So these numbers are pretty amazing. Okay. So what I want to show you are sort of these 4 areas that we have data on. I'm going to sort of describe for you what information we have and how we get it, and then kind of point out the information that we don't have. But I want you to see sort of what we know about abuse of prescription drugs in the state, what we know about abuse of over-the-counter drugs, dietary supplements, or your typical gas station drugs, and then illegal drugs as well. The first sort of big category of data that we have comes from our prescription drug monitoring program. So the PDMP, if you're in law enforcement, you certainly know what this is. If you're somebody who prescribes medicines or you dispense them in a pharmacy, you certainly know what this is. But the state of Alabama, like most every state, has a big electronic database that tracks prescription controlled substances, all right? So if somebody gets a narcotic prescription or some other type of controlled substance, that information goes into this database. It's a confidential database. We actually run it and maintain it within public health and don't even have access to it. So we can't look up things in there. But the prescriber boards, like the board that oversees physicians or the board that oversees pharmacies, those folks have access to it when they're trying to look for bad behavior. Law enforcement has access to it. If they have a case open, then they can ask us for information from that. And so we are able to keep really in great detail track of the number of pills that are being dispensed and the type of pills and how strong they are. And really the takeaway from this slide is you can see over the past 7 or 8 years actually a decline in the number of those pills being prescribed and dispensed in Alabama. That's actually really exciting. As recently as about 2012 or 2013, there were enough prescriptions written in this state for every man, woman, and child. I think there were almost 2 narcotic prescriptions written every year for every man, woman, and child in the state of Alabama. Those numbers are just absolutely staggering. We don't know that Alabamians have more pain than usual. We don't know that we need stronger medicine than people who live in other states, right? We're like everyone else everywhere else. But for some reason, narcotic prescribing was really out of control compared to most of the country. So a great deal of work's been done on that by a lot of you in this room, but many different folks. So law enforcement, the prescriber boards, the physicians board, the pharmacist boards, the other prescribers who prescribe narcotics, right? It's not only physicians, it can be dentists, it can be podiatrists, it can be optometrists, it can be other licensed health professionals who do that as well. The folks in mental health have done a great job in working with people who actually have those substance misuse issues, and so we hope to lower demand. But in a lot of ways, we've seen a lot of successes there. We've seen those numbers decline. We're actually really proud of that. There's a lot of mandatory education that goes for all of those groups that I mentioned who are prescribing or dispensing those products, and all those things have helped. What we have seen, though, unfortunately, is an increase in other things that sort of make up for that deficit. I want to point out that stimulants are also something that we can track, controlled drugs that are stimulants, and that number has fallen off quite a bit. But as you're going to see in a second, stimulant use overall continues to be a tremendous problem here, and one that we honestly don't talk about maybe as much as we probably should. All right. These are sort of the 3 big buckets of information that we have in public health that address overdoses. So the first one is what we call syndromic surveillance, all right? Syndromic surveillance is a program that we have that connects with Alabama hospitals where they can report to us information on certain things that we would like for them to report to us on. We capture a lot of data in public health through laboratories. Like you go and get a test, and the test is for tuberculosis, and the test comes back positive, and the lab lets us know, and we know there's a patient with tuberculosis. Well, those mechanisms don't work that well when you're trying to evaluate something like substance use or substance misuse or drug overdoses. You know, they're tests for drugs, but you know, they're not always done, and many of them are in people who are supposed to be taking those drugs. And so just reporting of that information to public health doesn't work in the same way. So we have a, you know, somewhat manual process of working with hospitals in the state to get syndromic surveillance. So they can say, we have a person who came in and they were obtunded, and, you know, maybe they had needle tracks and they got Narcan and they got better. And so we think this was an overdose. And so we can take that information and we can, our epidemiologist will plug it in and see if it counts or doesn't count. But that's how we're able to count some of these things that we don't have actual lab data for or numbers for or actual results for. So syndromic surveillance is really important to what we do. We also are able to track the use of naloxone, or Narcan is one version of naloxone, which, as you know, is the opioid reversal agent, when it's given by our EMS units, by paramedics and EMTs. Those folks are regulated by public health, so they report that information to us. So we are able to see, you know, in fairly real time, you know, hey, we've got a county where EMS units has, you know, given naloxone 7 times, you know, over the weekend. That's really important because it's really the best information we get quickly to understand when there may be something going on within the community. And finally, we have vital stats data. We're the agency responsible for birth certificates and death certificates, and also marriage and divorce certificates. And if you want any of those things, you can go to any county health department and get that. But our folks who work in vital stats are also the ones that will collect death data on causes of death. This is actually the hardest one to get timely information out of. It takes a really long time to get vital stats information because they have to be really careful. Our state, just like every other state, is really careful about how they count things because we want to be able to compare state to states in an apples to apples kind of way. And so most of our death data and cause of death data is about a year old before we feel good about using it. You know, we update it all the time, and we may find out information about an Alabama resident who died in another state, and it happened 2 years ago, and we finally got it, and we go back and update those numbers for 2 years ago. So it's not always the easiest information to use in a timely way, but it's actually a really good information that is very important in telling the story, but just really kind of only one aspect of the story. So syndromic surveillance, EMS reports of naloxone, and vital stats data are really the 3 big buckets that we have in public health that we're able to use. All right, let's see if it's going to change. Thanks for bearing with me here. I think it's got a mind of its own. Oh, there it goes. So you can see here, these are drug overdoses presenting to an emergency room as stratified by age. And really the dark line under there, the one that's mostly on the bottom, are actually drug use in those under 18 years old. And you can sort of see those numbers. And they're, unfortunately, beginning in about 2000, starting to increase. These are not just drug overdoses, but opioid overdoses in general, okay? And you can, again, see that number. We had a fairly flat number, at least we weren't capturing maybe all of them, but we had a fairly flat curve even before this time, starting in about 2019. But starting in 2020 with the pandemic, we began to see opioid overdoses increasing throughout Alabama, and that number is really worrisome. Okay, fine. I'm gonna go here. This specifically looks at fentanyl overdoses, and we're gonna hear a lot more about this today. You know, if you're here in this room, you know, you understand the impact, I think you do, that fentanyl is having right now. This is a scourge really unlike any illicit substance that I've ever dealt with in my career. And we're going to, again, learn a whole lot more about it. But these are ER visits for fentanyl overdoses. And, you know, this misses a lot of them, right? You know, so a lot of these fentanyl overdoses don't make it to ERs, right? For various reasons, some good, some bad. And there are many cases of drug overdose that come in where a substance isn't identified, right? You know, you don't actually have a substance. You treat them with Narcan and they get better, but you don't know what they had. You know, your toxicology is not done in a lot of cases, and many of the routine sort of urine drug test toxicology are not going to differentiate fentanyl anyway. So these are just, so I say that to say these are the ones we know about, okay? This is an undercount, and this number is definitely a lot higher than we think it is. Whoops. One more time. Okay. These are deaths from drug overdoses in 2018 through 2022. There's two lines on there because one of them is sort of by residence. These are Alabamians who die anywhere that we have information, whether it's in our state or not. The lower line are the people who die within the state of Alabama, you know, wherever they come from. It's kind of interesting to see that divergence because there are a lot of Alabamians who die from drug overdoses who don't live here. You know, we're a state that probably in general has a negative migration into our state. We probably have more people leaving than coming, and it's sort of reflected in these numbers. All right. Stimulant overdose deaths, we deal with that problem quite a bit with prescription stimulants that we'll talk about, you know, that are particularly popular with young people, but also the ones that people manufacture at home as well. That number has fallen off just a little bit. Not quite sure why we're seeing that. Certainly usage hasn't fallen a lot, but at least the number of deaths we're capturing has fallen off just a little bit. And these are total opioid-related deaths, and then what I wanted to show you here were, if it'll go back, fentanyl-related overdose deaths, 2018 through 2022. Again, these are the ones that we know about. We don't always have toxicology on this. This is clearly undercounting the number of cases that we're having, but you can see that trend. Maybe for 1 year, maybe it's flattened out or declined a little bit, but I will tell you, the further out we get, since this is death data, that number is going to increase because the death data is not our best data early on, right? You know, it takes a year or two for that death data to be complete. So we expect that that's probably not actually decreasing at all. Okay. Let me mention a few things around over-the-counter medications. You know, abuse of over-the-counter medications happens a lot, right? And it reminds you to check and see what you've got available in your house, particularly if you have people who are prone to do those things. Combining over-the-counter medicines with other things, you know, particularly alcohol, is particularly dangerous, but also particularly common. There are a lot of things out there that can be dangerous when used in the wrong way. I think education over-the-counter medications is one of the things that we don't think about a lot. You know, we tend to think if we can go purchase it legally without a prescription that it must not be dangerous. It's, you know, probably safe to use, and hopefully you remember to read the panel, but not necessarily. You know, not everyone does that. But that's a particularly not as nearly as big a problem as illicit substances, but it's a particularly emerging problem that we're going to have to spend a lot more time thinking with. And dietary supplements. Dietary supplements are, you know, sounds like a great title. They're just supplements, right? But this is really kind of encompasses a great big group of things that are just unregulated. These are things that are sort of sold anywhere, and they might be sold at the health food store, but they might be sold at the convenience store. Many of these are things that are known to be dangerous. They're things that are, you know, not legal in other parts of the world. But at this point, you know, in our country or in our state, you know, the regulatory boards just haven't gotten around to regulating those things yet or making them illegal. We spend a lot of time playing whack-a-mole with these types of products because we can get a legislation or we can get our State Committee of Public Health to regulate something or to ban something for a while, and these manufacturers go and change a molecule here and there and just sort of reformulate it just a tiny bit, and suddenly they're technically exempt from that legislation. I think the two big battles we fought recently have to do with tianeptine and phenibut. Tianeptine, as you know, was just sort of the classic gas station drug that stimulates a lot of the same receptors that opioids do. It has a lot of addiction potential. People have serious withdrawal when they use tianeptine regularly and then come off of it. We had many different stories from families who had people caught up in the throes of addiction to this. And these are just the kind of little bottles you see at the checkout counter when you pay for your gas or when you go in to buy a soft drink. These things, they look kind of harmless. They're marketed towards kids and young adults in the way that the advertising is done with them, and they can be really powerfully addictive. Tianeptine has been outlawed in many parts of the world. It's not used. It has a it technically does have some medical uses in some cases, although it's rarely used. And so for that reason, DEA in this country has not chosen to schedule it yet. Probably they will. But several different states have just individually gone out and made it unavailable in their state. And so Alabama was one of the states that did that. I was really proud of our state for doing that after talking to so many people that dealt with that. We had hearings in the legislature where the distributor of tianeptine came and presented his case about why the drug ought to remain legal. And his case was, this makes a lot of money for us, and the state gets a lot of tax dollars off of it, and you shouldn't make it illegal because you're going to lose tax dollars. And that's, certainly one argument, and honestly, that argument resonates with some people. But the other side of the argument was it really harmed people in a tremendous way, and I'm grateful to our legislature for recognizing that and making this unavailable. Phenibut was another product that instantly replaced tianeptine. As soon as tianeptine became illegal, phenibut started arriving in the same bottles with the same packaging with just a word changed on the label, manufactured by the same people. And ultimately, we were able to have that removed from store shelves as well. So these things continue. We have some other products that we're tracking now. I think you'll hear more about this today, but there are many different cannabinoids or many different derivatives of marijuana that are currently unregulated because there are dozens or maybe hundreds of individual chemicals, from cannabis, and many of those, are being extracted. Many of those, have hallucinogenic effects. They're just not regulated yet, and so we continue to deal with that problem. We're particularly seeing issues now with those type of products, cannabinoid derivatives, being added to food and drink. Okay, in some cases, you have people who are manufacturing a food product or they're manufacturing their craft beer or whatever, and they look at these cannabinoids that aren't regulated and they go, well, this is legal and that's legal, let's just mix them together and we can sell that. And that's exactly what they're doing. They're not allowed to do that, but it's really difficult to catch them, and it's really difficult to sort of prove what's going on without a lot of really extensive work to prove the source of where they got their stuff. The US FDA has said that is not legal and that they can't adulterate food and drink with those type of products. The US FDA has also said we don't really have the ability to stop this. It's a multi-billion-dollar industry. We're just not able to regulate it very well. So individual states have started to do that. We have not yet done that in Alabama. We're working really hard with legislators to try to get them to understand the importance of doing that. But some states have said you may not add any cannabinoid derivatives to food and drink, even though, even in states where some of those things are legal. So we hope to get to that point as well. But, it's a big industry, right? And these are, business people, and they have a lot of money invested in these industry, and they're looking for new markets for their products. And so, we don't want to get in a war with someone again over how they make a living. But when it has an effect on the health of our population, particularly our kids, we feel like it's our place to do that. Okay. Just takes a second. Sorry. Let me try one more time. Okay. Illicit substances. Again, I think most of you all know all about this, but somewhere around 150 people a day right now are said to be dying from synthetic opioids. That includes things like fentanyl. Fentanyl, remember, is 100 times more potent than drugs like morphine. It doesn't take much at all, and fentanyl, as you know, is beginning to adulterate all these other products that we see out there. You're going to hear, again, I'm not going to spend a ton of time on that because you're going to see a lot more about that today, but many counterfeit pills now contain fentanyl either on purpose or perhaps inadvertently, so it really doesn't take much exposure at all to result in a really bad outcome. Let's see. We'll try again. Wow, it just does its own thing. It's amazing. Okay. All right, we'll go here. Again, as I mentioned, counterfeit pills that are laced with fentanyl are becoming increasingly common. 2 milligrams of fentanyl is a potentially lethal dose. That's such a minute amount, it's hard to even show you how small that amount is. We're seeing issues with fentanyl laced with xylazine, which is, trank that you've probably heard about. It's been a news story recently. We've not had a ton of cases in Alabama that we're aware of, probably less than 10 to this point. But xylazine is a veterinary sedative. It has a lot of legitimate uses. The government's really trying to figure out how to keep this drug available for veterinarians who really need this drug and really use it regularly, and yet regulate it so that it doesn't continue to contaminate these products. Xylazine in particular, when it's injected, causes serious skin necrosis. It causes damage. It causes sort of eating away of skin, producing these large ulcers that are really difficult to heal. And so xylazine is on our radar now, even though we haven't seen tons of it yet. It's been a particular problem on the West Coast where it is being found sort of inadvertently in lots of combinations with fentanyl and with other substances. Okay, just keeps going. Okay, I'm going to try to stop there. I did want to say just a thing or two about naloxone before we finish up. Naloxone, as you know, has recently become over the counter in some of its formulations. Naloxone, or Narcan, is the opioid reversal agent. It's not the only one. There are actually a couple of others that are going to be introduced pretty soon, but naloxone is the one that we've had the longest. It's available as a nasal spray or as an injection, or it can even be given orally. Naloxone is incredibly important, as you know, to be used in a timely way if someone has an opioid overdose. We have several years ago provided a standing prescription, on our website for any Alabamian who wants to print that prescription off and take it to a drugstore and get naloxone. It has always been a prescription drug, so to save people from having to make a doctor's visit and go have maybe a potentially uncomfortable conversation, we just put that prescription on our website because it's a drug that is actually really innocuous. It's really safe to take. There are virtually no side effects from it, almost none at all. Really anybody can use that drug if they need it in most cases. So we have encouraged people to have naloxone available if they have a loved one in their home who is using opioids, illicitly or not. Even people on ordinary prescription opioids will benefit from having naloxone available in their house. The real issue, the hardest problem we've had is that even though we can make that drug available through prescription to anybody, we've not had the ability to buy it for people. It still can be expensive. And, buying naloxone in a bottle for injection like you might use in a hospital or emergency room is incredibly cheap. It costs pennies. Buying it in a nasal dispenser can cost a good bit more. These automated sort of dispensers that are battery powered that don't really require any training to use are the most expensive. And so not everybody has access, even though they might have a prescription to it, to get it. The fact that Narcan has now gone over the counter, will help somewhat, although we still don't know what the price is going to be. But one thing that's important to understand is that only one single formulation of Narcan is over the counter. Most of the brands of Narcan are still available only by prescription. We're going to continue to have our prescription out there for people who need other formulations of Narcan. The over-the-counter strength Narcan that's just been made available may not work for all overdoses, particularly really powerful things that involve fentanyl, for example. We've already seen many cases, people who overdose who require multiple administrations of Narcan in order to respond. So we're still going to have Narcan prescriptions available for anyone who needs them. We have worked with Jefferson County Department of Health on naloxone distribution. Dr. Mark Wilson, Dr. Darlene Traffitstadt have run that program, and Dr. David Hicks have run that program. They make naloxone available to anyone who wants it and send them the naloxone. They basically have to agree to read or view a little training program. You can go to their website and do that and fill out your information and, attest that you've done that and understand how it works and when to use it. And then they will actually send naloxone to you, which is a terrific program. We would love to expand that statewide. It requires money. That's the big issue. But I know many of you here are doing things with naloxone, and we would love to find ways to partner with you to get that out to other folks. We have programs who have gotten naloxone to many law enforcement agencies in the state, to volunteer firefighter groups, and to fire and EMS as well. We're continuing to try to identify ways to do that. We simply have to find ways to pay for it and get it out there. But I do believe over-the-counter Narcan is going to make it more accessible. These slides will be available to you if you like, by the way, so please check this out if you have an opportunity in Jefferson County. And let's see what else. See if it goes one more time here. Well, there we go. So you can see that actually during the past year, about a 220% increase in the number of people requesting Narcan. They've done a terrific job with that, and we're very proud of that. Most of that's been centered in Jefferson County. That's where most of our naloxone usage actually occurs, but we're actually very proud of that program. And ADPH can't take credit for that. That's from Jefferson County Department of Health, and we really appreciate that. All right, I think I'm gonna end on that, but I'll be happy to answer any questions, Dean, if we have time, or if I need to go sit down, I can do that too. But listen, thank you again for being here. I know it's a lot of really difficult, challenging stuff to get through, but I hope you will take what I've shown you. Please reach out to us if we can work with you or we can help you with that. We definitely want to do that, and if anyone has questions, we'll be glad to do that too. Thanks. Yeah. Yeah, so the question had to do with Narcan availability in public schools, and I would say it's really spotty. There are some cases, I know of some cases that have done that. I know our universities have done that fairly widely, but in K through 12 schools, it's not widely available, but it has been available in some of them. Again, making it over the counter makes it a lot easier, I think, to do that. Having a prescription drug available without, immediately someone to prescribe it and dispense it has been the challenge. But some schools have done it, but not most. So, okay. All right. Listen, thank you again very much. Enjoyed being with you. Thanks.
Thank you, Dr. Harris. I want to say again, thank you so much for being here. You're going to hear me say that throughout the day because we really are appreciative of your time and effort to be here today. I also want to say thank you to our partners who are at tables around the room. When you have time, and especially during our lunch break and this afternoon when we take our break, please go and introduce yourself to these folks and allow them to introduce themselves to you, get to know them a little bit better, because they are giving of their time to be here today, and they might even have a nice little giveaway to give to you as you come up and visit their table. I also want to tell you real quickly about how we ended up in this facility. We ended up in this facility because Central Alabama Community College wanted to come to Prattville. And most of you know I live in Prattville and was on the city council for many years, and we wanted Central Alabama to come to Prattville. And it so happened that East Memorial Baptist Church, who had a school which is connected to this building, ended up deciding to close their school. And so then they had a big building with nobody to put in it except on church days and when they had church appointments. So Central Alabama came in, bought the facility. The auditorium here still kind of technically belongs to East Memorial. They still worship here on Sunday mornings and on Wednesday evenings. They're building a brand new facility on Highway 14 as you go out past Chick-fil-A. If you look to the right, there is a huge site that East Memorial is building their new church on. But this facility was open to us. They allowed us to come in, and we want to say thank you to Central Alabama Community College and East Memorial Baptist Church for allowing us to be in this facility. I also wanted to mention to you, I know a lot of you are here today because you are getting your CEU, CLEs, continuing education credits. At the end of the program, we already have your certificates made up. All you have to do is pick them up on your way out, and then you are free to give those to your individual organizations that are giving you your credits. Law enforcement, of course, your credit will be given when you give your certificate to your supervisor, and they will get it through A-Post, and you will get your hours. I also want to say thank you to the fact that our speakers could not wait to get here today. They were so excited about being here. We even have a lady who you're going to hear from in just a moment who's coming from Boston. We have two folks that have coming from Iowa that wanted to be part of the Alabama Says Summit. So we are making a name. You are helping us make that name. You are making that name for us. So thank you for being a part of the Alabama Says Summit, our third summit, and hopefully the third prior to the fourth and prior to the fifth and so on. I cannot tell you enough about how much our planning committee means to the Alabama Says Summit. The planning committee is made up of individuals from state agencies and service providers. We've been working for over a year to put this conference together. One of our most integral members is Susan Short, who's from Covington County. She's with the Covington County Children's Policy Council. She is involved in many organizations that have connections to well-known and well-established and experienced speakers, and that's how we ended up with our guest speaker this morning with Dr. Madras. So I would like to ask Susan Short to please come forward and introduce our next guest speaker.
Good morning. Professor Bertha Madras is a research scientist, inventor, educator, former government official, elementary school volunteer teacher, and a public speaker. She can speak authoritatively on the many dimensions of drug use, from biology and addiction to public policy, prevention, and treatment. Internationally, she has presented at the United Nations, at the Organization of American States, the World Health Organization, the Vatican Pontifical Academy of Sciences, the World Federation Against Drugs, and others in 23 nations. On a national level, she served in the White House twice as a member of the President's Commission on Combating Drug Addiction and the Opioid Crisis, and as Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy, Executive Office of the President, a presidential nomination confirmed unanimously by the U.S. Senate. Dr. Madras is a professor of psychobiology at Harvard Medical School of 37 years, with her office at McLean Hospital and with a cross appointment at the Massachusetts General Hospital in Boston. Her neuroscience research has yielded more than 200 manuscripts, articles, books, book chapters, and commentaries. As an inventor, she holds 19 U.S. patents and 27 international patents with collaborators. A dedicated educator, she has developed courses on addiction biology for Harvard medical students and directed the production of a museum exhibit, a CD licensed by Disney, Changing Your Mind, Drugs in the Brain, in collaboration with the Museum of Science in Boston. She is a recipient of both research and public service awards. Her diverse experiences afford her a unique perspective at the intersection of science, public policy, and effective solutions. Today, she will speak on marijuana and the brains of our youth, the unborn and the born. Please join me in welcoming Dr. Bertha Madras.
Thank you very much, Carol. Susan Short and her husband Lex, they have both shown me what Southern hospitality is. They have been so kind during this journey from Boston. These are risky times for we, the people. For over the past few decades, there are vocal advocates in our nation who have ceaselessly tried to destroy our earlier premises on drug policy, to erase our tragic history of drugs, to erase the knowledge that we have accumulated on drugs, that drugs can bring harm from the mild to the extreme, from in utero to old age, depending on the vulnerability of the user. They have tried to challenge the scientific evidence. They have tried to challenge our personal, our family, and our national concerns by these drug advocates. They have paid for ballot initiatives, political campaigns, and media support to medicalize and legalize drugs that should neither be medicalized nor legalized. In the guise of what I call fuzzy logic, inconsistencies, and without restraint, they claim that drug use is an expression of free will, yet drug addiction is a form of chemical slavery. They claim that legalizing drugs will provide a safe supply for all of us, but they don't regulate safe use. When we had a prescription drug overdose catastrophe in our country during the early 21st century, those drugs were pristine. They were prescription drugs. They were pure. The doses were known. And at the height of the prescription drug problem, thousands were dying every year, not because the supply was safe, but because the use was not safe. They claim that we must meet people with substance abuse where they are, but in many cases, they want to leave them where they are and facilitate use and not offer treatment, especially treatment on demand. So let us begin with marijuana and try to understand where we stand. Marijuana is now a drug that has penetrated every sector, every corner of our country. Those of you who have collective memories know that this wasn't always the case. Those of you who have collective memories that go back decades, I'm 100 years old, so it's easy for me to remember things that happened a long time ago. I know what our history is only too well. This is a critical time for the developing fetus, because the developing fetus is in a critical phase for biological, brain, and physical development. It's a risky time for the adolescent because it's also a crucial phase for brain, psychological, social, physical development. And when exposure to drugs can have long-term consequences on mental health, on subpar academic performance, on substance use disorders and others. So let's begin this journey together, you and I, and thank you all for coming here, because your presence really makes me happy to know that there are so many people who are concerned about this issue and are going to give up a day, a very crucial day in their lives, to try to learn more about the. Now the challenge. Yes, this definitely has a mind of its own. So in 2023, we have a real problem in our nation. Many of the drugs that we use recreationally began as medicines. The opioids did. People thought of hallucinogens or cocaine. Cocaine is still a Schedule II drug. Many of these drugs began to be used as medicines. Then they morphed into recreational drugs. And now there's an effort to convert them back into medicines. There's not only an effort to do it, but there's also an effort, good heavens, to make all these drugs legal, safe, available, and commercial. And the question is this wise? I will try to dwell on only one other drug category, and that is the hallucinogens, in just a few brief moments, because that is uppermost in my mind right now. So, what we have found over this past century is that most accidental deaths in the US have declined. Deaths due to fires, deaths due to drownings, deaths due to poisonous gases, deaths due to falls, except for deaths from drugs. They have steadily increased, and we have a massive problem now, not only with overdose deaths, but with normalizing their use. So what will we try to address today? We can't talk about all of this because every single topic is an hour or 2 or 5. So let's focus on new marijuana and new potencies that are rising, the consequences of marijuana to the fetus, the consequences of marijuana to the adolescent, medical marijuana, the reality versus the myth, lessons that we have learned recently and over the past 20 years that we have to relearn now, and finally, what you can do. So what are Delta 8, Delta 9 THC? The big two in marijuana are Delta 9 THC, which is found naturally in the plant, and also cannabidiol. And they differ because one has a ring that's open, one has a ring that's closed. In one, There's a ring that's holding hands with a chemical bond. In cannabidiol, it's not. Now, delta 8, which you may have heard about, is simply a double bond. Delta means double, 2. A double bond that's found on a ring that's in a different place than delta 9. Why am I worried about delta 8 as a new form of marijuana? It's because they're increasing reports. This is just three cases of people who have used only delta 8 exclusively, and they have been hospitalized, one for 32 days, with violence, with psychosis, with paranoia, and had no history of psychosis whatsoever. The other 2 did. So delta 8 can produce some of the same effects as delta 9. There's only one problem with it. And the problem is that even though delta 8 is similar to and not identical with THC, it produces pretty similar effects. Wow, that entire slide. But we need to regulate it because it's made from hemp. It's made from cannabidiol. You close that ring, you join the hands of that ring together, and you can get delta 8 from cannabidiol, making it de facto legal throughout the country because of the Farm Bill that enabled hemp to be grown legally. And we need to reform the Farm Bill at the federal level. What we're also finding in this country is a trend towards increasing potency of regular marijuana, which is THC, delta 9. The potencies began between 1% and 3% in the native plant. This plant is no longer a natural plant like people claim. It's only a leaf, it's a vegetable, it grows. No, these plants are bred deliberately to increase the potency. Why? Because the more potent, the greater the high, the more tolerance you develop, which means you need to use more and more to get the same effect. You get more addiction, you get more users, and more profit. And if profit motive is what drives this country, instead of public health, we have to change our priorities, folks. So what are some of the risks of increasing potency of marijuana? Higher potency products in the biomedical literature are associated with greater progression from use to marijuana use disorder, greater severity of addiction to marijuana. In adolescence, there is a greater prevalence of past-year marijuana use disorder amongst the users of high potency. There's also a greater use and more daily use amongst the high potency. There's a greater risk for psychiatric problems. There's a greater risk for emergency department problems as the potency increases. At this rate, I'll be here till 4 o'clock until the slides advance. So what we're finding is that the more frequently a person uses, from monthly to weekly to daily, the greater the prevalence of cannabis use disorder. What about the edibles versus the inhaled? And emergency department visits, what are we seeing there? Because of commercialization, there's a wide array now of edibles and vapor products that can be vaporized, products that can be smoked that are very different than they were in the 1960s, the 1970s, the 1980s. And what we're finding is that there are differences in why people go to emergency departments depending on the form. For example, with smoked marijuana, there's more cannabis hyperemesis disorder, which means incredibly painful, challenging, difficult vomiting, non-stop vomiting that in some people can only be relieved by taking blazing hot showers. Whereas the edibles are giving rise to more psychosis, symptoms of psychosis. Because when people eat edibles, they don't realize how much they're taking. They can't titrate the dose. It can take a few hours to get into the brain. You know, how many of you, by a show of hands, have eaten 1/8 of a brownie? Or if you have a bag of gummies on your table, how many of you have eaten 1 gummy instead of 5? And you have no idea how much is getting into your brain because you eat them and there's no effect. You eat another one and there's no effect. And what's interesting is that within the edibles, in some places, this is, I believe, in Colorado, the market share is very tiny, but the share of emergency department visits is much higher, meaning that this form of marijuana is in fact giving rise, way out of proportion to its market share, it's giving rise to problems that call for emergency department visits. What about the consequences to the unborn? Past month daily or near daily marijuana use has increased in pregnant women. It's increased in terms of first trimester, second trimester, third trimester in the past decade. These are a little bit older, but they're still relevant data. And the use has increased with normalization, commercialization, legalization, medicalization. And what's fascinating about this is that a few years ago, Women's Health emailed me and said, we're writing a nice story about marijuana use in women, and especially in pregnancy. Can you help us? I said, of course. And I sent them 8 pages of email on why pregnant women should not be using marijuana. And instead, they wrote an article on how wonderful it is for pregnancy. And they completely ignored all the scientific data that I had sent them. So how could marijuana affect the developing fetus? In order to understand it, we just have to understand communication in the brain. When you and I have a discussion, which perhaps we'll have after this talk, one of us will transmit a message verbally, the other one will receive it and interpret it. That's exactly how the brain communicates. The brain sends out chemical messages because it doesn't have little voices with each nerve cell. And these chemical messages, in this case, happen to be endocannabinoids, cannabinoids that the brain produces that are not the same as THC, not the same as delta-8 or delta-9. And these chemical messages float across to a receiver, just as you and I are here, and we could have a dialogue where I send a message, you receive it, you interpret it. But when you introduce THC into the brain, what happens is THC is more potent than my own chemical message. It goes to its target, it floods the target, and the messages are very different. They're louder, they're stronger, they're distorted. Now, endocannabinoids, the the brain's own cannabinoids are critical for brain development. They're critical for deciding what kind of cells to be made, because there's so many different types of cells in our brain. Does anybody want to guess at how many brain cells we have? Anybody? I guess? Try? Someone brave? Please. How many? Well, we're close. We have about 80 billion nerve cells and about 1 trillion supporting cells in our brain. And all of these have to be wired incredibly carefully. Now, let's say you have 10 or 100 numbers on your cell phone. If you dial a number and one number is wrong, you're not going to get the person you want. When these cells hook up and make connections to other cells, they have to be absolutely precise. They have to be able to connect to the right other neighbors. They have to travel to the brain to connect from the base of the brain to the front of the brain with perfection. Otherwise, you get brain diseases. Inability to walk or to speak or to think clearly. And the endocannabinoids are critical for wiring the brain, especially during fetal development, right after birth, and even including in adolescence. So, what happens when you introduce THC in the developing fetus? It changes the signaling system of the brain. It creates mistakes in how these nerve cells migrate to their targets, because nerve cells, they send out like arms to reach the targets they want to in order for us to be able to see or to move a muscle or to speak or to think. And if THC is present, it can interfere with this migration, this arm that's floating around trying to find the right target. It creates mistakes. It reorganizes some circuits. And in the end, what happens? Because cannabinoid systems are all over our body, they don't only affect the brain. Marijuana use in pregnancy increases the risk of preterm deliveries, of neonatal intensive care unit admission. It decreases mean birth weight. It also decreases head circumference in babies, and it decreases the APGAR score. The National Institute on Drug Abuse has sponsored the Adolescent Brain Cognitive Development Study, which is a study of about 11,000 kids, starting at the age of 9, and they're going to follow them for a very long time. And so far, because this is going to take years, they've already looked at 9-year-olds and at 13-year-olds. What happens if their mothers used marijuana during pregnancy? And they have found a number of changes already in terms of brain changes, in terms of cognitive function, in terms of sleep disorders, and probably more distressing of all, they find that 9-year-olds who've been exposed to marijuana in utero have what they call psychosis proneness during childhood, which means they have more symptoms. They're not psychotic. They don't have full-blown psychosis, but they have certain symptoms that are suggestive of having a brain that's not functioning normally any longer. So, in summary, prenatal marijuana exposure can change the brain of children. At birth, it gives rise to small birth weight, premature delivery, in admission to the neonatal intensive care unit. It can produce deficits in function in terms of attention, in terms of other forms of behavior. It can also affect sleep. And these are longitudinal studies, which means you start with kids that have not used marijuana at all. The only difference is that their mothers used while pregnant. And they have already shown that there are problems in all these domains, these functional domains, as well as the brain changes, psychosis, and sleep disorders. With unregulated edibles in the home, we've also seen little children eating them because they are tantalizing. They look just like normal candy. And we're seeing pediatric poisonings that have risen 1,375% in one study. And there are many different reasons why the poison control centers are called. But this is another example of an unregulated industry working towards profit above all. What about the adolescent? What are the consequences? Let's look at teen brain development. The teen brain is undergoing massive changes during those precious years from, let's say, 12 up until 25 and even 30 years old. The teen brain increases gray and white matter. It prunes connections. Pruning is critical. It strengthens connections. It changes function. It's a very critical time for brain development. And what are we finding? We're finding that the United States leads the world in cannabis use disorder, marijuana use disorder, amongst 15 to 19-year-olds. That can't be good for our young people. It just cannot be good. What we also find in terms of youth is that people who are 12 to 17 years old and they use marijuana frequently, by the time the fourth year of use has gone by, about 20% are liable to develop a cannabis use disorder. If they delay it until they're older than 18, it's only 10%. So that it shows without a shadow of a doubt that the young brain is more susceptible to addiction than the older brain. And that's true for a number of drugs. It's true for alcohol, it's true for opioids, it's true for benzodiazepines, for cocaine, for MDMA, for other stimulants. And what we're finding that is so worrisome is that more youth are using marijuana daily now than ever before. And what did I say earlier? The more frequently you use, the more likelihood you will become addicted, and the more likelihood that the child will have consequences. What are some of those consequences? What are some of those consequences? The consequences are that more frequent marijuana use before the age of 17, the worse the outcomes in terms of other drug use, in terms of suicide attempts, in terms of cannabis use disorder, in terms of high school completion, getting a university degree, the use of other illicit drugs, depression, and welfare dependence. This is an earlier longitudinal study that showed how much a child uses during their teen years can affect adversely whether or not they get a college degree, whether or not they're on welfare or unemployed. Of course, we have to consider reverse causality. Kids who use marijuana frequently during teenage years may be troubled in other ways, may have conditions at home in their lives that drives them to escape by using, and all these consequences are just coincidental or associated, but not causative. We always have to bear that in mind. By the way, I have my computer here. Is it possible for me to hook up my computer? And
So glad you said that. We have a laptop, we want to connect it, but I didn't want to interrupt you.
yes, please,
Will, let's hook up the laptop.
because this computer is definitely not fun.
And it worked perfectly yesterday, but of course, that's IT.
You know, it inhaled marijuana yesterday, and it's simply not exquisitely sharp today. Please bear with me, but it's really difficult to have a flow when things are not functioning the way.
Information is far too important to worry about skipping.
Because I've been skipping stuff that just gets lost in the. Is this an old or a new laptop? Yeah, it's got to have a plug-in.
That's where you're plugging it in? I'm just gonna use my laptop. Okay. We'll fix it after. Yeah, so all we're gonna, you're actually controlling what's on this back screen, but all you gotta do is just use your arrow keys right here, and you can just go right there.
Oh, thank God. Thank you. Well, we're back in business, folks, and this is wonderful. So let's continue our ride. By the way, this is like getting a drink out of a fire hydrant. There's a lot of information here. So, IQ, adolescent marijuana use. This is again, so let me try to explain what the meaning of a longitudinal study is. There's many different ways of doing studies. Some of them are weaker than others. The strongest studies are longitudinal, which means you take a group of people and you follow them all the way through, a progression from childhood to adulthood. There are very few studies like this. Why? Because you run out of money to do the studies. The longest study that I'm aware of is the Framingham Heart Study, which started in the 1940s and is still continuing. And you can follow multiple generations of people and find out, for example, what George Vaillant did is that alcohol causes depression and depression causes alcoholism. And because they followed people for literally almost 80 years and their children. So longitudinal studies are the ones that I tend to believe more, or it has more credibility, because you're following individuals to see their natural course. And Madeline Meyer, who's working at the University of Arizona currently, she was able to excavate a longitudinal study from Dunedin, which is in New Zealand. And what she found is that continuous use of adolescents until they're in their 30s led to about an 8-point decline in IQ. Now, some people say 8 points, so what? 8 points is not important. But IQ predicts access to university education, lifelong total income, access to a good job, performance on the job. And in this study, she found that in the persistent cannabis users, they had less skilled jobs than their parents. You know, every generation wants to improve on the previous. This one did the reverse. They had poor memory and attention. It was not explained by tobacco, alcohol, or illicit drug use, except by marijuana, or a family history of substance use disorders. Adway Whitaker, who's actually studying now and believe in the University of North Carolina, did this study showing that the highest risk before the age of 18 for developing opioid use disorder, a spectrum of addiction to opioids, the highest risk was marijuana use before the age of 18. And all the other risk factors like mental illness, an encounter with a drug seller, age or health or access or income, all these others were less important than using marijuana before the age of 18. We know that vaping amongst adolescents is a real problem because there are so many ways to disguise the use. Vaping disguises the cigarettes, it disguises the smell, it is easy to hide it. You can disguise it in writing pens, in backpacks, in hoodies, in smartwatches, and iPhones, and USB sticks, and vape pens, all of these methods of hiding marijuana use amongst young people. And it is a problem both for cigarettes and for marijuana use. Why? We have had a fantastically spectacular decline in cigarette use amongst kids, the lowest in our history. In the past 30 days used among 12th graders, before 1980, it was 40% of our young children were smoking cigarettes. In 2021, it's gone below 10%. That's a spectacular gain, where so many now believe that cigarettes are dangerous for your health, for your future. And what has happened to reverse that gain? Vaping of cigarettes. It's going up and up and up. The same trends we're seeing with marijuana use. Kids, marijuana use flows and ebbs depending on how they perceive the drug to be harmful. But now, right now, marijuana vaping is increasing rapidly. And what's the problem with both? Here is the problem. If you smoke marijuana or you vape marijuana, you're 3 times more likely to use tobacco products than if you don't use marijuana. And if you use cigarettes or e-cigarettes, you're 3 times more likely to use marijuana. They're completely intertwined. Now, what about high-potency marijuana? What are the risks for young people? Let's compare high potency with low potency. With high potency, there's more regular marijuana use, there are more use problems, there's use of more illicit drugs, there is more tobacco dependence, there's more alcohol use disorders. All of these are exaggerated by kids who use high potency marijuana with more than 10% THC. The adolescent use of marijuana edibles and vaping is associated with psychiatric symptoms in children. I call adolescents children. I know because I was a child when I was an adolescent. My children were children when they were adolescents, and so are my grandchildren. Psychiatric symptoms are associated with the use of combustible, edible, vaporized marijuana, and they're higher in poly-product use. More conduct problems, more depressive symptoms, more sensation-seeking, more anhedonia, which means getting less and less pleasure in life from other sources of pleasure. Adolescent marijuana use has effects on physical health, on sleep, insomnia, insufficient sleep at school nights, shorter sleep time, later bedtimes. It has effects on lungs. EVALI, as you all know, hit the stage in 2019, which is associated with lung injuries. This is a form of vaping. Reproduction. Nobody knows what a safe use of cannabis is in the context of fertility, pregnancy, and breastfeeding. Heart and cardiovascular system. There is increased episodes of heart attacks, of atrial fibrillation, where the heart loses its rhythm, its incredibly essential pumping rhythm, and starts to just flutter and not pump properly. In terms of stroke, in terms of very high heartbeat rate. Adolescent marijuana use has effects on the gastrointestinal tract. Hyperemesis, withdrawal, leads to nausea, pain, and appetite loss. And it also has effects on the hormone system in terms of disrupting cortisol function and a decreased stress reactivity. So I'm just going to deviate for one moment, if you bear with me, because I'd like to give you one vignette of the research that my lab is doing and what certain other labs in the country are doing. We took a deep dive to try to explain if there's something that we could uncover that may be related to some of these symptoms in adolescence. We took a deep dive into genomics and what's called proteomics to see what is it? Is there something that we can find? And this is called essentially a fishing expedition. Instead of saying, I have a theory on how this happens, we said, let's take a look at the big picture. And what we found was completely and totally unexpected. And Yasmin Hurd at Mount Sinai Hospital in New York has found the same things, so we're beginning to feel comfortable with this data. We started with a brain region that we thought may yield us some new information. Not the same old reward system, but the amygdala, which is like an almond-shaped, tiny little organ in the brain that contributes to Darwinian survival. It controls behavior to find the necessities of life, food and water. It assesses the resources, threats, and safety. It gives rise to emotional responses of fear and anger and depression. It's a very critical brain region. The signals are manifest as anxiety, fear, aggression, and others. And the damage to this brain region can impair these functions. This is well known. For example, one woman who's a case study for years in the neurology literature did not have a functioning amygdala. And she did not have normal stress reactions. When people approached her, she lived in a tough neighborhood, people approached her with a gun, she would smile and say, "How are you, dear? How can I help you?" She trusted everybody. She had none of the normal instincts of aggression and fear. And she lived a life that was quite remarkable because she did not have this Darwinian survival in this brain area. What we found which stunned us. And it was so stunning, we did it in 3 different labs. My lab, the University of Toronto, which was the first to make the discovery, and at MIT as well, that there are certain so-called supporting cells in the brain called astrocytes that are critical for normal brain function. And they produced a marker of inflammation, a marker that there's some toxic effect going on in this brain region. We didn't find it in other brain regions, only in this one, only in adolescent primate brain. Yasmin Hurd found it in rat brain. And we thought to ourselves, could this be the clue that helps us understand why the adolescent brain is susceptible? And we found a huge amount of endocannabinoids signaling in this brain region. What are the implications? This brain region is completely implicated in depression, in anxiety, in compromised cognition, in psychosis, in sleep disturbances. So maybe this is going to lead us to trying to understand why the adolescent brain is more susceptible in some functions. And this marker, it's called GFAP, or glial fibrillary acidic protein. This marker is blocked from going up, increasing, if you block the cannabinoid receptor. So, to summarize, the adolescent marijuana user is more susceptible to brain changes, to addiction, to deficits in cognition, to amotivation, to psychiatric symptoms, and functional and health deficits. All of these and more. And safety. Now we'll just turn quickly to mental health problems that can affect not only adolescents, but adults as well. Psychosis and schizophrenia. Many of you have probably heard that some people believe that marijuana causes psychosis. Others say that's bunk. Let's try to walk through what the evidence is. Psychosis is characterized by suspiciousness, paranoia, by bizarre thoughts which are delusional, by fragmented thoughts, disordered thinking, and by hallucinations of hearing, of seeing, of feeling, of smelling. All of these are symptoms of psychosis. Only one can occur, or 2, or 3, or 4, or more. Now, let's discuss what correlation versus causation. Does marijuana correlate with or cause psychosis? So here's an example of correlation and the fallacy of it. In May, the sun is hot. It gets hotter and hotter as the summer goes on. And in the northern parts of the world where Alabamans never experienced, there is snow and ice and fierce storms. And then we begin the cycle again. Now, what happens during the warm summer months? People eat more watermelon, they drink more lemonade, and they have more heart attacks during the hot months because they're more outdoors, they're doing more activities, they're less confined. Now, what's interesting is that wars also begin in the summertime. Because, why? Obviously because the weather's more favorable. Russia started its invasion of Ukraine in February because the snow was easing up, the freezing was easing up. Most wars begin in hot climates. Now, would it be ridiculous to say that watermelon causes wars? Or lemonade? Or heart attacks? That's what correlation is. It can be completely and totally absurd. But here are some of the criteria for causation. There's consistency in different places. Early onset use of marijuana increases the risk for psychosis in different nations. Studies in the UK and Germany, New Zealand and Israel and Sweden and the US, the Netherlands, all have shown, regardless of country. So it's not a localized thing. Marta DeForti in London did a study in 11 cities, but primarily in London, in Amsterdam, and in Paris. And she showed that the more marijuana that's used, and the more frequently it's used, and the more potent it is, the risks of developing psychosis increase dramatically. In fact, Amsterdam is one of the worst because they're actually cutting back on potency now because they recognize the folly of it. So, in the US, psychosis associated with marijuana use rose. It rose from any non-users, there was a certain risk. Any use, frequent use, and cannabis use disorder, the prevalence of psychosis increased. And in a study, this was a very, very huge systematic review. So what is a systematic review? It means you take all the biomedical literature, everything you can find, everything you can lay your hands on, and you look at studies that describe only adverse consequences, or you look at studies that describe therapeutic benefit. A systematic review has much more power and strength than a single report from a single study, from a single lab. And in the systematic review, they looked at what is the frequency of mentions of adverse consequences. And what they found, they looked at frequency of use, THC content, age of onset, cumulative cannabis, and they found the most mentioned adverse consequences of marijuana use was psychosis, close to 93%. Psychosocial function, less motivation, a little bit less executive function, working memory, attention, anxiety, these were lesser. But the number one that came up in this analysis was psychosis. So let's see, what is the evidence so far? The strength of the association in different countries, the consistency, the timing. Marijuana use usually precedes the psychosis, the dose response, the higher the dose, the more frequency. So there is a sense that even though it's not settled, science is never settled, but there's more and more evidence accumulating that it could be a causative agent. In fact, in 1895, people excavated what they called then, pejoratively, an insane asylum in Bengal in India, and found that almost 40% of the people there had been heavy marijuana users. And they compared it to opioid use and alcohol, and marijuana use was much more prevalent amongst the people that had been confined to that hospital. What about marijuana and violence? I have accumulating evidence based on the literature that there is an association between marijuana and violence. There's all these papers that are listed below have addressed it, but there is among the reports of mass murders marijuana use amongst the Boston Marathon bombers, which happened, the Boston Marathon was yesterday, the Uvalde school shooter, mass shooters at Representative Gabby Gifford's constituent meeting, the movie theater in Aurora, the Pulse nightclub in Orlando, the First Baptist Church in Texas, at high school in Parkland, Florida. We don't know with certainty, but apparently, and this is from my perspective, it still is in the domain of science fiction because I haven't seen the reports of urine tests or any of the history of the people who were shooters. But the media is reporting that these were heavy marijuana users. I simply think the jury is out, but we have to keep that as a factor in mind. That's all. Medical marijuana, reality versus myth. 400 AD, a young woman who was 14 years old was buried in the Negev desert in what is now Israel with a fetus in breech position, and she obviously died at childbirth, and beside her were ashes. They weren't in her nose, they weren't near her mouth, they were actually near her abdomen. And the chemist living in Israel at the time when this was excavated raced ahead of the Orthodox community to gather the ashes in order to analyze it before this skeleton of this unfortunate girl was reburied. And what he found is that it had metabolites of THC in it. And he concluded that they were using marijuana to try to increase uterine contractions, because that's what marijuana does, in order to try to save her and the child. So marijuana has been known in history as some form of therapeutic. We didn't have a pharmaceutical industry 1,600 years ago. The reason they know it was 400 is they found coins buried with her with emperors of Rome that were emperors at the time of her death. So they assumed it was 400 AD. We've used opioids. We've used whatever plants we could find for medicines. We used mahuang. We used foxglove. We used the bark of a willow tree to try to reduce fever until we isolated aspirin. We used, I'm blocking on the pronunciation, a bark from South America, which was effective against malaria. So we did our best to try using plants to help us. But what's happened now with marijuana? Is it an effective medicine? Are recreational or medical marijuana the same, or are they different? The percent THC advertised online for medicinal or recreational is the same. 70% of the products advertised have more than 15% THC, regardless of whether or not they're used for medical or recreational purposes, and 15% THC is completely unnecessary and unsuitable. What is the link between medical marijuana and addiction and use for recreational purposes? Many people who use for medicinal purposes are using for recreational. Some estimates are as high as 80%, and some are a little bit lower. But it's very clear that the crossover between the two is very, very tight. And of those that use it for both medical and recreational, about half are reported to have a cannabis use disorder. And for those who use it only for medical purposes, so-called, about a third have a cannabis use disorder. So that the conflation between the two is very fuzzy. And the question is it really a medicine? These are If it is, why do different states list different medical conditions? In California, you have this. In Arizona, you have, cancer, glaucoma, HIV/AIDS, anorexia, arthritis, cachexia, cancer, chronic pain, and so on and so forth. In Illinois, you have 40 chronic diseases. In Connecticut, you have any medical condition. Folks, that's not the way one does medicine. Cannabis has been fraudulently hyped as a cure for opioid addiction, glaucoma, diseases of cancer, Crohn's, PTSD, Parkinson's, Alzheimer's, autism, or used for any other medical condition, pain, sleep, depression, anxiety, and many conditions for which evidence does not exist. I can't get into all the evidence. It's absolutely fascinating to go through what the really hard, cold studies tell you. But this was tested in a courtroom in the Eastern District of California in 2015, recited by Judge Kimberly Mueller, a federal judge. It was a federal court case. The defense attorney was Xenia Gilg. The defendants were people who were growing marijuana for medicine in Northern California. And there were U.S. assistant attorneys and the U.S. attorney for the Eastern District. And there was myself in this court artist. He painted my nails as these long claws that looked like eagle claws. I've never had long nails in my life because you can't work in a lab with long nails. But what was tested is whether or not marijuana is a medicine and should be rescheduled into a medical category or descheduled altogether and just become freely available. And it was, in fact, a very important federal case in retrospect. And this is some of the evidence that I presented. Does it fulfill the criteria for the Food and Drug Administration, which is charged with regulating the safety and effectiveness of our drugs in this country? In terms of purity, no. In terms of dose, standard doses, no. Quality control, some cases yes, many cases no. Clinical trials were limited. Do we have a good roster of safety and side effects? No. Do we have a specific medical condition that was tested instead of a shopping list of 20 or 40? What patients may benefit? Was it tested in children? No. Was there reported adverse effects in terms of acute or chronic, in terms of developing cannabis use disorder if it's used for medical purposes? None of these studies looked at that. How should the drug be taken? Eat, drink, vape? No. A safe drug dose for a specific medical condition? No. How the drug is made in terms of standardizing it across the country? What about its active and inactive ingredients? And the decision came out in 2015 by Judge Mueller. The court concluded on the record in this case, this is not the court, this is not the time. The court denies the motion. Marijuana remains in Schedule 1. So the FDA has approved cannabinoids. It's approved Marinol for AIDS appetite improvement and cancer chemotherapy nausea. It's approved Nebolone. It's approved Syndrose, Sativex in other nations, not in the US. Epidiolex, which is cannabidiol for rare forms of epilepsy. But no botanical marijuana has been approved. And that's why you can only recommend marijuana. And that's why most insurance companies will not reimburse it. The next wave, ladies and gentlemen, of our drug challenges are hallucinogens. They're coming so quickly, much faster. They are on speed dial in terms of penetrating state by state, through ballot initiatives, the exact same strategy that's being used. And it is so simple to claim that chronic brain disorders have a large public health burden, that the treatment needs are unmet or not adequate, that the indications are conditions of internalizing disorders like depression, anxiety, stress, where people claim they are uncomfortable, and in many cases they really are, and one has to listen to their voices. And all questions of drug policy are now being questioned. So this movement towards hallucinogens, there's now billions of dollars invested in promoting it through ballot initiatives, through road clinics, for all sorts of brain diseases, the same playbook as marijuana. And in many ways, I feel like Cassandra or Laocoon when I warn the country that this is another Trojan horse designed to introduce and legalize this class of drugs to the general public instead of restricting it to people who have gone through a rigorous system of medicalization and FDA approval. So what are the lessons we've learned? Vast sums of money were spent to promote opioids and marijuana, promoted for many medical conditions. For opioids, it was any form of chronic pain. They're safe, they're not addictive. That's precisely what the opioid industry said. Same with marijuana. The scientific evidence for chronic use was weak, as it is with marijuana and opioids. In terms of marijuana, many of the conditions are at the bud-tender's discretion. Medical education has lagged far behind. The advocates, the proponents, the ferocious people who show up at town meetings, who go to the editorial boards of newspapers, they're the ones who receive attention. The opponents are marginalized largely. Youth use is high. High-potency drugs are flooding the nation. Fentanyl for opioids now, and very high-potency THC. The medical and recreational uses are being conflated, and government regulations have failed to protect the public. What can you do? What can you as individuals do? Just recognize that marijuana use and use disorders are rising, primarily in adults of childbearing and child-rearing ages, primarily in the wrong population, when they can have enormous influence on their children. And this study that we published in 2019, this was a consortium between the CDC and NIDA and SAMHSA, showed that if offspring live with mothers or fathers who use marijuana, they're much more likely to use, much more likely, whether they're 12 to 17 or 18 to 30. So I ask you to go forth and speak out on the hazards of drug use during pregnancy, on the hazards of drug use in adolescence, on the hazards of potent drugs, high THC, on the importance of parental influence on offspring drug use. Cory Booker this week called marijuana a dangerous drug, and he says he's frustrated with a non-diverse industry. It's a dangerous drug. I really do think we haven't studied it enough. And the other side of the political spectrum, President Trump said the same thing this past week. We have now people who are waking up, even in the political domain. So I close with one thought, 1 minute over, one thought. This is not a war on drugs. The brain is the repository of our humanity. It is where we seek justice, where we administer laws, where we write poetry, where we love the next generation and people around us, where we can send rockets to the moon and the Webb telescope 1 million miles away with absolute precision, where we can write wonders of literature and develop new therapies for cancer. All of this comes from the brain, our repository of our humanity. I want you to consider this not a war on drugs, but a defense of our brains. Thank you.
We have a couple of minutes for questions. If anyone would like to ask Dr. Madras a question. You must have done a fabulous job. Whoop, there we got one right over here.
I either did a fabulous job or a terrible job. Please ask. Yes, ma'am. It's a great question. Thank you. So the question was, is there evidence that marijuana use before conception can influence the offspring? Is that, yes? Wonderful. So Yasmin Hurd again, she's one of the smartest scientists in our country. She did a study a number of years ago in which, and I know this is rat, but there is a punchline, in which she gave male rats THC only during adolescence, not after. And then after they grew into adulthood, she had them mate with female rats. And lo and behold, they had little infants who had never seen THC. They had never been exposed to it in the utero. They were only exposed, the parents were only exposed during adolescence, but not during adulthood, when they mated and when they gave birth. And the offspring of those adolescents using marijuana, THC, they had brain changes that were visible, and they consumed heroin at higher rates. Now, there's more and more evidence that those experiments have validity. More and more people are beginning to jump in on the bandwagon and look as to whether or not there are what we call epigenetic changes in the germ cells. So what does that mean? In the past, the dogma was that when an ova and a sperm are produced, they are stripped of all the environmental influences that they have, so that the new child that comes out of an ovum and a sperm has no history of what the parents have experienced in terms of stress or drugs. And it appears that that is not true, that these epigenetic changes get transferred in the germ cells and can influence the outcome of the children. Does that answer your question? That was a great question. Thank you so much.
Thank you, Dr. Madras. Thank you, Dr. Madras. We appreciate it so much. She came all the way from Massachusetts to be with us. So I just want to give her another round of applause, please. I mentioned to you before we got to Dr. Madras that we were very proud of our planning committee. Another one of our planning committee members is Miss Loletta Jenkins. Miss Loletta works for the early childhood department, and she's going to come and introduce our next speaker, Miss Loletta Jenkins.
Good morning. Well, I have the pleasure of introducing our next speaker. In my work with children's policy councils across the state of Alabama, I often hear the horror stories of children that are overdosing on fentanyl. So I am looking forward to learning information today at this conference that I can apply to my work and also share with children's policy councils across the state. So a little background about Eyes Wide Open, the program that we'll hear more about. Kristen and Ginger Hatfield, mother and father to Christian Hayes Hatfield Jr., will share the story of losing our eldest son to fentanyl poisoning on August 30th, 2022. Join them as they share the signs, the struggle, the fight, and the sacrifice they experienced during this experience. They will share their experience and discovery that led them to form the Fentanyl Awareness of Alabama. They are hopeful that their story will not only be informative, but emotional, but remain a catalyst for us all to stand firm. You know, as we come here today, we came looking for answers. We're looking for ways to be able to provide prevention, intervention, and ultimately save lives. So please join me in welcoming Kristen Hatfield, the Executive Director of Fentanyl Awareness of Alabama. So let's give him a hand as he comes.
Just let them right on.
We're at, just right here, all right, just these two dots right here? All right, fantastic. All right, well, I don't know whether to laugh or cry. This is my first time ever to speak, y'all, so just bear with me. I'm Chris Hatfield. Pictured as Ginger Hatfield. She's over here. We're the parents. We're the parents of 4 boys. On the left, coming from the left to the right is Ethan. He's 21. Griffin, 22. Addison, who's 26. And Hayes. He's forever 28. Ginger and I were together for 25 years as boyfriend, girlfriend, husband, wife, and although we are just friends now from divorce in 2015, we're still family. Ginger and I formed the Hayes Foundation, doing fentanyl awareness of Alabama. And Ginger, I want to thank you for stepping up, walking this out, helping other organizations, other grieving moms, and other kids. Thank you for being my friend, and thank you for all you do. And I want to thank my friends and family at the same time that are here that help us make this happen. Thank them for all we're going to do for the fight against fentanyl, mental illness, grief counsel, and I'm honored to walk with her and my family, and I'm so proud of each one of you. Our foundation couldn't stand without you. As we set up our story, just know this is one of the toughest things I myself have ever done in my life. Speaking about our journey through the death of our son, Christian Hayes Hatfield Jr. Hayes was born January 9th, 1994. Ginger and I were just kids ourselves. She was 20 years old, and I was just shy of my 24th birthday. We accepted the challenge of parenting, so we got married and proceeded to raise a family. Our lives were forever changed from childhood to adulthood. And from this point forward, our lives had a different focal point for us. Hayes grew and excelled as a young man. His school studies were second to nobody. He had computer skills at a very young age and allowed him to have an edge over his peers. He just had a different approach in his ability to understand, and he was always smarter, quicker, and more detailed in his answers to the questions that he may be faced with. He was intrigued with math, science his whole life. He could recite the periodic table at the age of 7, and that kind of wittiness never left him. He still had it even till his final day. He had dreams becoming a pharmacist, a lab technician, a world traveler, a musician, a husband, or maybe even a dad. So what happened? Best we can tell, he struggled to fit in with new friends in a new school. And we had moved to Birmingham from Florida in 2006 at a critical time in his life. He was 12 years old. The first sign of trouble was when he was a freshman in high school. He was caught at school with a broken marijuana pipe that he had found in the gutter at the bus stop. He was suspended and placed on probation. We, the parents, dug in, got closer by creating other activities in his life, and his favorite was guitar lessons. At or around the same time, he was diagnosed with ADD or ADHD. He described it as his mind racing at such a fast rate, and he could not slow it down. It started to create sleep disorders as well. This was probably our first real sign of mental disorder / anxiety, and this is us looking backwards after his death. While this was taking place, he just kept trudging forward, making the grade, learning the guitar, and growing into a fine young man, 16 years of age. We did not think much about his signs of insomnia and ADD. But looking back, we see these as the earliest signs, and to us, they are major signs that he was struggling from some form of mental instability, rejection, and a struggle to slow his mind. We missed it. We thought he would grow out of it, and over time, it seemed just that way. Little did we know it was there the whole time, and the significance of this is a major player in his coming addictions. Hayes is 16. He does not think he fits in, and he lands some friends that allow him in their circle. A circle of friends that soon find their way of life, a life of getting high. But not the marijuana high we all might think we would do in high school. Nope, it's heroin that he gets introduced to. We had no idea this was even going on and off for most of his high school years. He really did not look any different than what we would expect. A high school prom, friends, grades, etc. In fact, Hayes graduated with honors and an ACT score of 30. He was a genius for sure. He decided to put college off and found a life of hard knocks more appealing than chasing his formal education. He chose to be close to his girlfriend and his family. He even started chasing a career in his daddy's field of automotive parts. Even after graduation, his on again, off again use of heroin was never evident. He totally functioned as normal. So normal, we had no clue at all. Then every now and again, one by one, over the next 10 years, his friends were dying, either from overdose or suicide. I only know these things after the fact. Later in his life, he shared them with me. The deaths among his friends really hit home with him and many others that were caught up in the same nightmare of drug use that began at Hoover High School in 2010. For the next couple of years, you would have never known there was a problem. He held a job, ate dinner with his family, and just did what young adults were doing at the time, playing video games, hanging out, working. We never knew he had a problem till one day he told me what had happened out in Tarrant, a suburb of Birmingham, and not such a great place for Hoover young adults to be. They had been busted for heroin possession by Birmingham Police Department, but they let them go. He was very honest with me. They prayed to a God they did not believe in. This was a milestone in his life because he had made a decision to stop using heroin and begin being a more responsible, hard-working young man. He was now 21 years old. While all this was going on, we did not take into consideration his depression, his anxieties, his rejections, the sleepless nights that still continued, or the parent wounds from divorce. We, the parents, so caught up in a survival mode from financial instability, divorce, and the pains of life, we just totally missed some of the signs of his struggle. He looked normal, acted normal, or so it seemed. It seemed that his life was right on track. Kicking the habits, he started helping others with their car troubles and excelling in his job, his music, and his friends. He had beat addiction, and he was doing well. In 2018, at the age of 24, he had an old female friend show up at our house. They used heroin, had sex, and the rest is history. This began his downhill journey to an uphill fight. We, his parents, now divorced, living under two roofs, had no idea his drug use was back. For almost 2 years, we had no clue, except he would occasionally say he was suffering from anxiety and was depressed some days. He was still functioning every day till March 2020, when his job laid him off and the government paid him $875 a week. Slowly but surely, his problem escalated, and it was not long before I started asking questions and calling out his problem. I was only looking at the addiction because that's all I could see. Lack of knowledge, I guess, and just like most, the root of the problem is not addressed. In August 2020, he agreed to a stay at the Foundry in Bessemer, Alabama. This is such a great place. But at the time, COVID scares and full dorms made it a very uncomfortable space. He lasted 3 weeks, and all of a sudden was back home on my couch one day when I got home from work. I was not very happy, but understood the situation, having taught small group there for 7 years. He is back home, and the pattern of substance abuse continues for another month while we continue to find a facility that maybe is smaller and more oriented to Hayes. We found Turning Point Recovery in Thorsby, Alabama. We raised the funds, got him a bed, and he did well there, better than any other facility. He still came home early due to COVID, but he was clean. He was himself, and so we brought him home just before Thanksgiving 2020. He did well for about 6 months. That no job and $8.75 a week, yeah, what a deal that was. It fueled the fire. He was clean about 6 months, and then it started again. But this time things changed, and they changed quickly. He was no longer functioning like before. No cares, no baths, no clean clothes, and no reason to get a job. His only desire to get high. But now the heroin is fentanyl or fentanyl mix, and the addiction is unstoppable. It is raging like a runaway forest fire. He now knows his problem has escalated. Now 28 years old, and he now considers his anxiety and depression like a cage with no way out. His fix is dope, but the dope is a monkey he wants out of too. We continue to look to find help for him, but lots of red tape, lack of resources. Yeah, you can't be able to read those, but it's okay. No insurance and turnaways. Some associates may be in this, hang on, we missed a whole bunch. Dope is a monkey that he wants out of too. We continue to look to find help for him, but lots of red tape and lack of resource. No insurance and turnaways. And some associates may be in this building that turned him away. We could not find any help local, and listen to me, we could not find help. No insurance, no money, and free help was degrading to his life. It's in a neighborhood where he scored the dope from. He was in a catch-22. We now know of a few resources, but at the time the answer was no, and it was not because we weren't looking. This needs to be fixed with a state list of resources broken down by city, not only in Alabama, but in all 50 states. I have began a resource for this, but it could be years before I get it done. He knew he needed help. You can see in this text from his mom, which I don't know if any of y'all can read it, but what he plainly says up there is he's going to die. If we don't find him help, he's going to die. And that he's in a cage, and that life is not very good where he's at in his life. So he texted his mom, and he was asking her for help because he knew he was going to die from the poison. Ginger found him a bed in Pike County, Kentucky. It's McCoy territory of all places, but nonetheless, it was a bed, a facility, and a hope. In just a few short weeks, he sounded good. He was agreeing to stay, but was feeling homesick. And I get it. Different state, all alone, and not sure what your outcome will be. He stuck with it for a bit longer, and due to circumstances, they moved him to another one of their facilities, a little closer to the city. And for us, we were like, he is getting help. He will be home soon. He will be home soon enough, and we'll get our son back, and everything is going to be okay, or so we thought. The cleaner he got, more reality touched him. The voices on the inside started showing on the outside. I talked to him on the phone, and his thoughts are completely twisted. He now showed some signs and forms of mental illness or mental instability, but yet he was still very much coherent. His reality check showed, and the second facility moved him closer to Lexington. They also gave him his phone, and he wasn't broke. And I told Ginger he knew his way around the city, and he would be home in 9 or 10 hours. And sure enough, he was at home by 10 o'clock at night. And although he was at home, we were not very happy with him. He said he had some kind of revelation in the facility, and he had to come home. He thought he was a daddy. This is still a possibility that we are pursuing. Although he found his way home, his mental instability was certainly present. Talking to things that weren't there, denying any form of responsibility, and challenging your knowledge. You couldn't win because, after all, he was a genius, and that part still worked just fine. At this point, he was clean but confused with life and priority. I'm not sure what the next picture is. Yeah. He had determined he was a daddy and proceeded as such, and had ended up scaring his friends off because he was determined to be the daddy, but ended up with restraining orders. This is certainly a part of the disease we do not understand or have figured out to this day. We, the parents, were lost. We reached for help and found none. This would be the lack of resources, and the resources judging our son and refusing him treatment. You can't see that real well, but what that text message is where he went for psychiatric evaluation and he couldn't receive no treatment and had to make a new appointment. I will not talk publicly about these places, but if you want to know, you can reach out to me privately because it needs to be addressed. Some of you may be shocked by one of them. So, that next text message is the week later with the new appointment. They turned him away. That was August the 29th at 2 o'clock in the afternoon. What we found out about this day, looking backwards, he hadn't slept in 3 days, and all he wanted was something to go to sleep on. They denied him. He filed a complaint with the state. He reached out for something else and self-medicated about 8 hours later, and I found him dead. But that's just some back information, so as we read. He self-medicated and died from fentanyl toxicity. He smoked it off tinfoil. And on August 30th, 2022, our lives changed forever. I found him dead. Let's see if it'll change. On my kitchen floor. He just looked asleep. But whatever he did, it killed him instantly. His toxicity level was only 0.007 Ng, and that is super low. Even the coroner said it was low. Whew. So parents, teachers, friends, coaches, doctors, do not miss the boat on this one. Psychosis is real. Talking to things or beings that are not there and seeing a dream as reality, and reality as false. We were totally lost and not sure what to do. So we locked him down, hoping he would snap out of it. 12 weeks and no change. Laying on the couch for days, music blaring, and no worries at all. We missed the boat on this one for sure. The laying around feeling useless, that's a sure sign of depression. The music blaring loud, he was silencing those voices in his head and the words of his music, crying out for help the best way he knew how. We missed it, and we are now talking so you don't. We thought he was just using drugs, but after it was all said and done, we figured out he was clean. This drug test was administered on August the 28th at about noon, which was a Sunday afternoon. Stuck in some form of psychosis. And as his parents, we attacked it as addiction, used tough love and ultimatums. Following advice for other drugs or other people's advice, you know. They just need to hit rock bottom. Well, when you're dealing with fentanyl, yeah, you can't use tough love, y'all. Fentanyl, it is a different demon. It does not discriminate. It does not respond to tough love. It just kills. We thought it would never happen to us. We thought hopefully tomorrow there would be change. We also really did not know about fentanyl and its pathways of destruction across our nation. We thought it would never happen to us. And we did a little research, and As I step into this next portion, this is just kind of some of the discovery I made along the way. What you're looking at right there is just the 9 analogs of fentanyl. There's only 3 for human consumption, and that's great on a medical scale, but out here in the streets, it's more like bathtub gin. There's no consistency, there's no exact potency, and to this day, I think my son smoked carfentanil, which is 10,000 times stronger than heroin or morphine. Not just 1,000 or 100, it's 10,000. And I'm thankful he didn't suffer. He wasn't blue or gray, he just looked asleep. He never moved again. Brings me to the next form. The PSA put out by the DA for the xylazine mixed with fentanyl. We got a little bit of that earlier. These drug mixtures causing necrosis. People slumped over for hours. I just couldn't even understand why somebody would even want to do any of this mess right here. Brings us up to something else we haven't talked about, super meth. So this new super meth that's out here in the world, even the best meth in the old days was 53% pure. This stuff is 93% pure due to something they put in it called P2P. That's short for phenyl 2-propanone. And it's different than earlier designs in meth. This gives you no rushing heart, it gives you no warning that, whoa, I might be geeking out and I need to take a break. Nope, you just keep using it because you don't get that same high and you end up overdosing with it. And just like the fentanyl, the meth causes paranoia, hallucinations, and schizophrenia or psychosis. You can't read that either, but for the most part, it shows that this article right here was a very good article. I wish it was bigger, but this guy did a 2-year study on addicts and the psychosis and what they were using and so forth. But the fentanyl and the super meth overdoses, which starve the brain for oxygen over and over and over and over, create a permanent brain impairment. That slide right there just backs it up. It just basically says that there's extreme psychosis with prolonged use. Brings us up to vapes. So that stands for Hays County Sheriff's Office. It's in Texas. I ran across this in September, even though that is dated January 2023. The liquid fentanyl that they're now finding throughout the country is what we need to be really concerned with as well, because you see it right there, liquid fentanyl in vapes. And it continues to run. This county had a big, massive problem with just regular blood screens coming back with trace amounts of fentanyl in them. And then we're talking about middle schoolers and high schoolers here. And what they determined was it was the sharing of vapes, that it was in there somehow, some way. So that right there shows you that's the largest liquid fentanyl seizure. I think it was in somewhere around Houston, Texas, about 2 or 3 months ago. And that right there shows that even in Alabama, we've issued our own warning right here for vapes and fentanyl. Brings us to the edibles. Those 5 brands right there in the state of Pennsylvania tested positive for trace amounts of fentanyl. There's controversy over that, but what if it's one every so many bags? We're not producing this stuff. We don't know who's behind the pushing this fentanyl. The DEA says it's Mexican cartels. They say it's the Chinese. Either way, they say that it's in those 5 brands of edibles right there. Some are THC, some are Delta-8s. Right there you see that even in Selma, Alabama, in a high school, a simple edible bought right at a convenience store. That slide right there brings us to this portion right here. All this information needs to bring awareness to our youth. The relaxing of marijuana laws is just opening the gateway to harder and stiffer drugs. These drugs are not the drugs of yesterday. These drugs are synthetic and they kill. When we were young, if I went out and bought cocaine, I got cocaine. If I went out and bought heroin, I got heroin. If I bought a pill, it was that pill. And today, all illicit drugs contain fentanyl. Our new slogan, because I've seen one pill can kill. I had one before, it was called one and done. Now it's just any drug one time. Because recreational use of drugs is now a thing of the past. The chart that you're looking at right there that you can't hardly see, that is a little chart that Bill Yates from Jefferson County Health Department, the chief deputy coroner there, sends me every few months if I ask for it. That total right there totals 448. There might even be a few still pending. I know there was a week or two ago. But as of December 30th, 2022, drug overdoses in Jefferson County totaled 440, it's still 448. When you put it all together, it's 448. But what you'll find up there is that there was 41 xylazine deaths, only 18 heroin deaths, and a whole bunch of opioid fentanyl deaths. But what also you need to know is that every one of those deaths contained fentanyl in their system. Whether it was the xylazine that killed them, the meth that killed them, the coke that killed them, there was still fentanyl in their system. It was still present. So on the morning of the 30th of August, I said to myself, and keep in mind, it's 4:30 in the morning. I said to myself, we have to do something for others in His name. I mean, it was just in my heart. Ginger lives 37 miles away from my house. She gets there about 6:15. She opens the door, gets out of the car and says, "He's not dying in vain. We have to help somebody else." So we had the same heart at the same time in two different places. It was at that time we knew God was at work. Right now, some of you are saying, "I could not imagine." Trust me, you do not want to imagine or even come close to the pain of this tragedy, the death of your child, the anger, the coulda, shoulda, woulda, the unfavors of life. Trust me, this is not a good place to be, but at the end of the day, love conquers all. And we knew we would walk in pain, suffering, and sacrifice. If we could just make a difference in just one life, it would be better than none. We immediately focused on helping others and formed the Hayes Hope Fund. This is us partnering with Turning Point's Brian Stockard. They are a great facility, a great bunch of folks with great intentions. This also led us to look around our country and state, and what we found was devastating. What we found was 13-year-olds and 15-year-olds and 17-year-olds buying a pill on Snapchat, eating dinner with their parents and waking up dead, not waking up the next day, mom waking up and finding their child dead in their bed. That's what we found. We found some moms not losing only one child, but two. And the way they found them, some of them weren't as pleasant as the way I found my son. I'm thankful. But this slide right up here, I received Monday from a friend of mine I grew up with. He lives in Atlanta. He wanted some information on how to speak to 200 young men. 2 weeks ago, This gentleman that's spoken about in that slide right there bought 6 Percocets on Telegram. They were leaving Friday morning. It was a Thursday he bought them. They were leaving Friday morning to go to Panama City to cruise the Strip, to live the dream of 17, 18-year-olds on a spring break trip. He decided to eat one of those pills on Thursday night, and that's exactly what happened. His mother found him, 17 years old, dead in the bed. They rounded up the other kids. They found out everything that happened. They addressed it. They found 5 other pills. They all were fake Percocets, all containing fentanyl. So what did we find? We saw that families became totally destroyed, dads, sons, daughters, uncles, all from fentanyl. Then reading about the 13 to 18-year-olds buying drugs on Snapchat or any other platform, trying to be cool, self-medicating, wanting Adderall or Percocets or Xanax or many others, forms of drugs out there, experimenting at its best, eating dinner, retiring to their bedroom, thinking they're going to be cool, that they're going to fit in, have something to talk to about tomorrow, and being poisoned from the fentanyl. These discoveries through the word of mouth, social media, news reports, police departments, DEA, and companions. I get about one of those texts about once every 2 weeks. It's been going on since September 1. It's way too many. So this led us to keep going and form Hayes Foundation, doing business as Fentanyl Awareness of Alabama. And you can see our slogan, it's any drug, one time. We're so far out of our comfort zone, and it's so much bigger than who we are. But again, God is at work here. He qualifies the unqualified, and here we are, soaking up all we can to become a player in this game of prevention, awareness, recovery, and restoration. Will it play, or do I have to hit play?
My son,
We made this
He had
PSA
his
for
hopes,
spring
his
break.
dreams,
It
his
aired all over the
passions
state of
ahead of
Alabama.
he had his goals. He lost them in one bad mistake. He's now forever 28. He made one wrong choice. Now that spring break is upon us, parents, it's time to have that talk with your child, that fentanyl kills and that there is no recreational use of any drug in our market today.
To get involved and help stop this epidemic, go to hayes-foundation.org.
I have no idea how many people that touched, but I own it, and I sent it out to, Lexington, Louisville, Kentucky, Memphis, Chattanooga, Nashville, Savannah, Atlanta, Augusta, Pensacola, Panama City, Tallahassee. I sent it all over. So I have no idea how many times it aired in other markets, but it aired over 30 or 40. It aired between 30 and 40 times on BRC in Birmingham's market. So we look forward to partnering with you all. We look forward to having our own facilities, fundraisers, and movements. We've set some long-term goals. Something doesn't seem right, but it'll be all right. And we will get there as long as the funding provides. On September 17th, 2022, I spoke at my son's funeral. I spoke of a coalition being formed to combat fentanyl poisonings, and I have to say it again, God is at work here. I'm looking at my coalition. I've met with Adam from Compact. I've met Candace, Jefferson County Health Department. Ginger and the girls actually worked with her in this slide right here, packaging Narcan kits. We met a few people with Addiction Prevention Coalition. I'm involved at Turning Point. I'm involved at the Foundry. And we'll meet with many, many more, and in time, we'll grow together. We want to stand in the gap for many who are fighting for their life. We know after just a short time that the addict would rather use than fight. As a coalition for saving lives, we must stand in that gap because we are the front line. Parents, teachers, friends, family, please do not run out of resources and default to tough love. Right here is where the disconnect happens with your addicted loved one, especially when the mental instability shows up. The voices in their head, the depression, the anxiety, and talking to things that are not there and laying around listening to music as loud as it'll go. Parents, pay attention. Parents, listen to that music and hear those words. We missed it, but God did not. Our son was healed eternally, and we will see him again. I want to share a few people with you. This is Luke and his wife Jordan. Luke's 33. He is currently the only one left out of my son's friends. He struggles every day with his fight, but he is determined. God protects him and his family daily. And I'm proud of Luke, and I thank him for allowing me to use him today. This next person is on the far right of that picture. He was supposed to be here today, but he couldn't make it. His name is Ken Turner. Ken went through Turning Point, and God has made me and him great friends. Ken is a recovered meth addict. Ken now attends Highlands College, and he has a lot of things going his way. His family is restored, his job is restored, and his leadership is restored. And I thank Ken for allowing me to use him today, and I'm proud of him as a brother. This next person, his name is Andrew. Andrew is currently in Turning Point. Andrew was rescued inside his car, overdosing. They had to bust his window out and administer Narcan. Andrew is the proud recipient of our Ace Hope Fund. He is our first sponsored addict through Turning Point. He is in recovery. God's doing a great work in him. He's in his 4th week this week. And God's going to do great things through him. And I can't wait for his testimony to come alive. So why did I show you these grown men and my son at a youth summit? The answer is simple. They all started using drugs in middle school. They carried baggage along the way, just like so many grown-ups do right now. So folks, we must pay attention to the signs of rejection, divorce, anxiety, pain, depression, and try to address these early to keep the child from becoming an addict or worse, a fatality. In closing, I'm hopeful that our story and our mission has not only been informative and emotional, but it will remain a catalyst for us all to stay the course in hopes of saving lives through prevention, awareness, recovery, and restoration for families across the state of Alabama. I was going to play a song, but this speaker's really, really loud, and I mean, we're good. We don't have to play the song. I just wanted to let you know that, hey, the words in this song, yeah, if you listen to them, you'd know that your child was screaming for help. And it's Tyler Childers' song, so any of you, if you don't know who Tyler Childers is, look him up and start listening to some of it. Oh, somebody's got it. Fantastic. Whew, it's a short one, y'all.
Daddy worked like a mule mining Pike
County coal. Thank you all.
Fucked up his back, couldn't work anymore. He said one of these days you'll get out of these hills. Keep your nose on the grindstone and out of the pills. See the ways of this world and it don't lie and don't steal. Keep your nose on the grindstone and out of the bill.
I told him not to do that, but we got to know each other over the last couple of months getting ready for the summit. Now we're brothers.
Absolutely.
Cannot imagine. He said, you don't want to imagine. He's right, I don't. Cannot imagine what it means to stand here and tell the story of losing your son. But we want to help him just a little bit. Alabama Says is going to make a contribution to the Hayes Foundation for $1,000.
It's gonna go to a good place. I love all y'all. I appreciate you letting me spend the time with you.
When I invited Christian and Ginger to come and speak, I didn't know at the time that he had never spoken before, but I felt like that regardless, his message needed to be told. And that message resonates, I know, with everybody in here because of what you do every single day in your jobs and in your homes and through your civic groups, through your churches. So let's not forget Hayes. Let's remember him as we go about our daily walk. I want to ask you to do me a favor before we break for lunch. Our friends at Laurel Oaks Behavioral Health Center have donated two door prizes, so we're going to give those away real quick.
Make sure I got one. I got one.
All right. Have it. Gail Bosworth. All right, Miss Gail. Venetia Jackson. Is Venetia here? Okay, there she is. I'll let you give that to her.
Absolutely.
I also have one more on the back table. Our friends from Bradford Health. It's on the back table. It's in the Bradford bag. And I appreciate them. Grab me one more. I don't want to grab it myself.
Okay, you good. I'm just glad to be a part of this. Here y'all got one.
Jasmine Harris. I know Jasmine's in the lobby. She's helping out, so we'll make sure she gets that from Bradford Health. We appreciate that. All right, now obviously we have a lot of folks in this room and it's impossible for all 375 of us to go immediately and grab a lunch. So what I'm going to ask is everybody from this half of the room this way, if you will go first. Everybody else just kind of hang out for just a minute because there's no way we can get everybody in the hallway. Get your lunch. You're free to eat out there or come back in here and eat at your table. When we come back from our lunch, we'll have some more door prizes. So please be with us. Don't go anywhere. We've got a lot more to go. advantage of them, and we're so glad that they were here to help pass out their information and their giveaways. We're going to start with a door prize. Just so you know, I'm going to do 2 right now, and then we'll do some more at our break, and then we'll do, of course, some more at the end with our 2 televisions. But these are going to be $50 Visa gift cards. So be listening for your name. You have to be in the room, so don't run out there. Here we go. Jada McDaniel. Jada McDaniel. All right. Cindy DeFore. There's Cindy. All right. Shalonda Cheatham.
She's here.
I hear her.
There.
There she is. All right. All right. You'll give that to her. Thank you. Congratulations to our winners. Perfect. All right, let's get started this afternoon. If you liked the morning, you are also going to like this afternoon. If you loved this morning, you're going to love this afternoon, because we have some great speakers to follow in the footsteps of those that came before them this morning. About 3 years ago, just prior to COVID, the Alabama ABC Board applied for a grant to look at what outlet density would mean to the state. And what we were trying to find out was, most of you know Alabama ABC Board operates 168 retail stores across the state. What you may or may not know is that Alabama is the only control state that also offers licenses to private licensees, to private package stores, if you will. There are 168 state stores, but there are close to 800 private package stores. So what we wanted to know is if those package stores were locating close to each other. And if they were locating close to each other, what was the impact to the community? There's all kinds of facets to that impact. So what we did was we asked if the NABCA, National Alcoholic Beverage Control Association, for an opportunity to put together a study. And we knew at the ABC Board that we did not have staff on hand that could actually do such an in-depth review and overview of what outlet density would mean. So we asked 2 of our greatest partners, Iowa State University, 2 researchers, Sean and Cass Dorius. They are both doctors. They are top-of-the-line researchers. We asked them if they would help us. What they have put together, I think, is going to amaze you this afternoon to let you know what outlet density really means to a community and how it's impacted. So I'd like to ask Sean and Cass Dorius to come forward from Iowa State University, and they're going to take us through our review of outlet density in Alabama. Welcome, Sean and Cass Dorius.
Well, thank you very much for letting us come. We are super excited to be here. And you can see on the screen we have a third partner in crime who is not here, and she was the lead analyst. And she is, as of today, 9 months and 7 days pregnant. So this is the only reason why she is not here, and she will be induced. But she keeps texting us and saying, now make sure you say this, make sure you do that. So she's very excited. We want to make sure we recognize her work. So we're from Iowa State, as Dean said, and we are part of the Public Science Collaborative, which is a science consulting group that just takes on public problems. And so we work a lot with state and local government to address sort of the big issues. And substance use and alcohol use are some of the biggest issues that we address. And we're here to talk to you about data, but we're really here to talk to you about the people and the stories that these data reflect. And all of us who are working in the Public Science Collaborative and the 3 co-authors on this work have had personal stories where we've been deeply impacted by substance use and by alcohol use. And I really appreciated Christian and Ginger's story and how they said, we do not want this death in vain. And we had a similar story with my brother who, this is as we're here for the Alabama Says, the youth summit. My brother was 16 when he started drinking very, very heavily, and that went until he was 39 when he died from his alcohol use. And that was one of the things that motivated me to come into this. So as we tell you the stories with data, know that we recognize that these are real people behind these stories, and we care about those people. And we're so glad to partner with Alabama in this work. All right, our team at the Public Science Collaborative. We work to amplify the voices of real people. So not only do we do data from federal, state, local sources, but we also go out and hold interviews with people with lived experience and ask them about what their experience is and how that might influence the way that we interpret and think about the data. And we work then with decision makers at the state and local government to try and improve the lives of individuals, families, and communities. And in Iowa, around the alcohol outlet densities that we'll talk about today, this has been a big issue because Iowa has the 2nd highest excessive drinking rate in the country. And when we got the call from NABCA to come and help Alabama, we were thrilled and wanted to give you all big high fives that Alabama actually has among the lowest binge drinking rates in the country. And you can see on the left side of your screen where it's kind of the blue and greens, that is the alcohol binge drinking rate. And the lighter color means it's the lower rate. And then the youth binge drinking rate, lighter color means the lower rate. So you're starting at a great place. It doesn't mean there aren't harms. We're going to show you what some of those harms are even here. So the bad news of what we found, especially when we talk to people and when we analyze the data, is alcohol causes real harms to individuals, to families, and to communities. And when we're thinking about the harms to individuals, I'll just name a few of the big ones that we know and we see. Now each one, I know these screens are a little bit hard to see here, but each one of these represents a different harm that there is a whole field of research that looks at. So alcohol consumption increases the risk of cancer, of liver disease, of fetal alcohol syndrome, of automobile crashes, of injuries, of those unintentional deaths, of violence, chronic illness, and then death. So at the individual level, we have people that are suffering related to their alcohol use disorders. But alcohol can also create harms within the family. So I'm a family demographer, so not only do I love data, but I love families. So let me tell you how this affects some of the families here. 2 in 3 incidents of intimate partner violence involve alcohol. And when you look at marriages, 3 in 4 of those incidents of intimate partner violence involve alcohol. It's one of the big reasons that when we consider the family costs of alcohol, we really want to think about how important it is to the way that it embeds in our relationships and changes the way that we interact with one another. And then that last little graphic with the big to the little, this reflects our intergenerational transmission. So what we find is when parents drink, it leads to increased exposure and trauma among their children. And also there's greater family instability resulting from that use. And both that trauma and instability are then tied to the children drinking as they age. And so we have seen this time and again in our interviews with folks where we talk to them about their past histories, about child removals, about what they experienced with their own family. And then as they've aged and created their own families, how alcohol has come into that picture and influenced them. But communities, which is really the focus of where we are today, when communities have higher alcohol availability, they also have costs. So most of the time, we're used to hearing about these individual costs and maybe the family costs, but there are significant community costs. So at the neighborhood level, if you have greater alcohol availability, you have more of those outlets that Dean mentioned, you have increased noise, neighborhood disruption, property damage, disorderly conduct. You have safety costs like violent crime, binge and heavy drinking rates, sexually transmitted disease, and you have economic costs like emergency service calls, hospital admissions, lost work productivity, and healthcare-related costs. The Centers for Disease Control estimates how much these costs mean in a dollar amount. And it's estimated that these costs of alcohol availability in communities cost Alabama nearly $5 billion each year. So, what can we do? This is where the data come in. So the Centers for Disease Control advises that we monitor alcohol outlets as a community risk factor. How available is alcohol in your communities, and what does that mean to the real price you're paying? So starting from the building blocks, what is an alcohol outlet? This can be liquor stores, gas stations, wineries, breweries, grocery stores, bars, and restaurants. All the places that you might go and buy alcohol are considered an alcohol outlet. And we're particularly interested when these alcohol outlets cluster together. And this is called an alcohol outlet density. So on the left side of the screen that you can kind of see, there's all of these little blue dots. And all of those blue dots are, this is a community here, all those blue dots represent an alcohol outlet. So someplace that sells alcohol in your community. Now on the right-hand side of the screen, you see those green and blue bubbles over those dots. And that's when those outlets are clustered together in such a way that they create a whole alcohol environment that's actually different than just a single outlet because they're together. And I'll give you an example. Laurel Muehling is this wonderful woman in Council Bluffs, Iowa, and she does intervention services around alcohol. So she goes into community schools and groups and talks to them about alcohol. And she was telling me that one of the schools that she goes into, there's not a window from that school where you can't see an alcohol outlet. That every single window in that school, in every direction, you can see an outlet. And that's what the kids have to walk through as they come into school. And when we think about those densities and what it means for our children, what it means for our families, it starts us thinking about what can we do. And this is where NABCA came in and brought us to Alabama. And I'm going to pass this off to Sean, who's going to show you the results when we looked at Alabama and your alcohol outlets and your alcohol outlet densities. And then we'll come back together at the end and think a little bit more about what we can do.
Thanks, Cass. Let's see here. Great. So just one quick background on this. There are states that control alcohol, and then there are states that do not control alcohol. We're in a control state in Iowa, and Alabama, as you know, is also a control state. And those 18 control states are in a national association, and that's how we got connected up. The National Alcoholic Beverages Control Association connected our two states together to work on a project. And so some of the things I'm going to tell you about come from this really great partnership. Our team in Iowa, the National Alcoholic Beverage Association, Alabama ABC, your alcohol law enforcement agencies, and some local communications team to facilitate all of this. And our goal is, as Dean said, to understand what's going on with densities in Alabama. And we had a little bit bigger goal as well here, and that's to think about, are there better ways to leverage these state and local data to inform alcohol risk education and to improve our prevention efforts across the state. As Cass mentioned, you have one of the lower rates in the country, and that's a really good thing. I'd like to share with you throughout the chat here today some tips and some strategies to make sure you keep it that way, that you don't become more like we are in Iowa, which is a place where alcohol culture is really doing tremendous harm. Second highest alcohol-related cancer rate in the country. And when we ask kids in Iowa, do you think binge drinking and excess drinking is a problem? They have the lowest likelihood of anywhere in the country to say, yeah. They think it's fine, they think it's normative because they're in an extensive alcohol culture. So our project, we started with data. Your teams shared with us data on those alcohol licenses. We did some cleaning and some classification. We partnered with the local police departments that I'll tell you a little about, got some other data, mixed these together. We measured density lots of different ways. How close is too close? And when does it become a problem? And then we gave back those data, some maps that I'll show you, and then a few recommendations based upon what we've seen in your data, what we know about you, some things that we think might help move the needle and keep the ball rolling in a positive direction. So when you get those data that your ABC has, here's some cool things you can do. One of the first things you can do is you can just do some counting. We all learned a little math in school, and it doesn't take fancy math to count the number of outlets and licenses in every county in the state. And once we do that, then we can sort and rank them. Which ones have the most outlets? Which ones have the fewest? As you know, some counties have lots of people, and other counties have very few. So it's also helpful not just to count the total number of liquor establishments and retailers, but also to adjust that for the number of people so that you know, is it just that there's a lot of people there? And when we do that both ways, we get some nice distributions. You can see, for example, as I share there, that Baldwin County, regardless of how we measure it, Baldwin County has one of the highest densities of outlets in the state. That's an area that we would be thinking there's probably going to be some excess problems in the neighborhoods and communities, higher risk and likelihood of underage drinking in that area because of the high density of establishments. In addition to ranking your counties and sorting and classifying in that way, you can also build cool maps. And we like to stare at maps because it reminds us that place matters. Where we live, where we study, where we go to school, where we have our good days and bad days, it's in a place. And some places are tough places to grow up, and other places are pretty great places to grow up. And depending on whether you grow up in a neighborhood where you're surrounded, as Cass said, surrounded by alcohol outlets, what that might mean is late nights and loud nights and bright lights. And kids growing up there, they're going to get less sleep, and they're going to have higher chronic stress levels. And as you've already heard in some of the substance use talks, when a young person has chronic sleep deprivation and chronic stressors from their environment, they're much more likely to have an issue like around with marijuana or opiates or any of these other problem substances. So the risk environment matters, and the alcohol environment is just one kind of risk environment. And as you can see in the map here, some of your counties have very, very high density of outlets, and some have lower. And that's a nice place to start. If you're in a state agency or you're a nonprofit that has that kind of state level view, staring at the data this way and knowing where to put those resources, where things are going well and where there may be problems, this is a helpful view. But some of you also work at a community level in a single county or within a single community, and maybe this scope is a little too wide. It's not really your playground. So we want to look at data in a few other ways as well. But we do ask the question, okay, now we've counted up. We know how many establishments there are, and we know where they are, and we know that there's a lot in some places and few in others. But what else can we do with those? And how can we detect if it's becoming a problem for a community or a family or an individual? So the map on the right, that's your outlets, and it's just per square mile. It's just a simple way to say how dense are they. The map on the left, that's your OWI, DUI crashes, the intoxicated driver car crashes that could include a fatality, and it maps those with a density. So the darker the green, the higher the concentration or the higher the number of OWI, DUIs. And if you just kind of do a little back and forth there, you can see a pretty strong association. The counties that have a large number of outlets, the dark pink on the right, those are almost always the same counties that have a high number of DUI crashes. And that's a real common association. You're not unique here. You're unique in all the right ways. And just like your parents told you all, we're all special. But you look like everywhere else. All across the country, the counties that have a high number of outlet densities also have a high number of DUI crashes and higher fatality rates. So that's maybe one place to intervene. If you work with, say, your Department of Transportation, There's good opportunities to pair up on some collaborative interventions, some safety messaging, and things like that. Another place you might get some value out of just knowing more than just that you have densities, have alcohol outlets in your community, is if you pair those data with other ones. One that when we work with local communities that we like to pair up a lot is 911 data, your dispatch data. Someone calls and says, hey, I need some help, my cat's in the tree, or I'm hearing something funny from the neighbor next door, or the house is on fire, or anything worse than that. Those calls get collected up by the dispatchers, and they get a classification on them. I've given you here classification data for Montgomery City. Montgomery Police Department was gracious enough to share a year of their dispatch data with us, so we could do this demonstration project and share it with you here today. So the top 10 counties are on the, the top 10 incidents are on the left, and you can see the kinds of call classifications: burglaries, domestic violence into family disturbances, stolen vehicles, things like that. Any number of calls. Well, when you count those up and you look at those, then you do similar to what we did with those outlet densities, put them on maps, then you start to see some interesting patterns. And let me show you what that looks like. So let me just describe this for you, and then I'll tell you what it shows you. The base map is purple. The lighter the purple, those are areas of town with very few alcohol outlets. The dark purple areas, which are actually kind of hard to see, those dark purple areas, those are the parts of town that have a lot of alcohol establishments, and they're in very dense concentration. That every street corner all along the roadside. Dark is the high level outlets. Those yellow dots then we've overlaid, those are all those calls from the last page I just showed you. That lets us say, well, where are the 911 calls? Where are those thefts? Where are those domestic disturbances? Where's the domestic violence happening? And I mentioned it's kind of hard to see the dark purple. It's because all those calls are concentrated right in the same neighborhoods in Montgomery as where you have your establishments. And back to, that's not unique. We find that in Atlanta. We find that in Baltimore. We find that in Chicago. We, our team, find that in rural Iowa. It's super common. It's a very established fact, much like the established facts we learned about with cannabis's effects on the brain and brain functioning. Established that you have a higher concentration of 911 calls where you have a high concentration of alcohol outlets. Our team worked with another group to calculate how much it costs to take one of those calls. The bare minimum is one police officer and one call responds to one call. One cop, one car, one call. That's $100. But as you know, you've seen lots of those calls. And it's often 2 police officers and 4 calls or cars. And it's 3 firefighters and 2 fire engines. And on, EMTs. Those calls, a single call could be anywhere of $100 to several $1,000s. And you get as many as 25,000 in Montgomery in a given year. And a share of those are because of that concentration around alcohol. Okay, so we looked at those data, we gave a few recommendations. We recommend, you heard a good strong advocacy for time series. All the trends in our first presentation saying things are getting better, things are getting worse, we're decoupling. That's what time series data, trend data have. We encourage you to build those time series, including with your ABC. Work with your ABC to build out a long time series, where your establishments are and how long they've been in operation. Build that out. Because if you're working in your community on local interventions, you want to know if they're effective. If they're working, you want to see declines in the problem areas. And if they're not working, you want to be able to switch gears so that you get the results you want. And having time series data gets you there. So we recommend that. We also recommend getting those data up in a public place so people like you can access those and make those decisions and drive your funding efforts and things like that. And then we recommend partnerships, state agencies and data like the ABC, local community groups, nonprofits, intervention groups. And then we recommend, you got cool data. I've just scratched the surface on what you can find there. If you get a chance to get some teams together and analyze those, it might drive some change as well. So let me just tell you about 2 of those recommendations for a minute here. One was, I said, get a dashboard. This is an example of what we built for Iowa. The map on the left is interactive. It's just on a website. You can go there. You can zoom in and zoom out. We map for the whole state where all those outlets are. So any community in Iowa, any organization, any nonprofit, any treatment center that's working on this can drive in and they can see where the risk factors are in the state. And then we also built a number of community-specific dashboards, similar to what I showed you with Montgomery, but for communities in Iowa, where we could infuse those local service called and other local data and pair it with your alcohol outlets. So you know the specific neighborhoods that are at risk. You know where you have a large number of underage youth that have high exposure, for example, and you can drive your education programming, you can drive your interventions, and you know where you're going to need treatment and other services. You know where you can expect more problems and get really focused with limited resources. So we recommend something like that. It's kind of high value. And it might look like something like this for you here. This is back to Montgomery. The map on the left, it's a heat map. We use this in criminology, it's called a hotspot map, and it's to find those places that are very high risk. We just mapped there all 26,000 calls for that 1 year in Montgomery. And then on the right is a map that we filtered the data down, and we only looked at the violence-related calls. And what you can see quickly there is the map changes. When we just look at violence-related calls, there are areas that are more likely to have calls and other areas that are less likely. And that's kind of nice because it helps us, again, to know where to look. And then so we got those call data, and then coming back to your alcohol data. When we layer those together, the purple overlays here are your alcohol outlet densities. That's where you have alcohol outlets in high concentration. And that lets you quickly, you don't need a PhD in anything fancy pants to be able to look at a map and say, I can see a relationship. I can see where there's a lot of calls around violence, and I can see where there's a lot of alcohol outlet densities. And that lets you know where to go for programming and interventions. And when we did a little bit of statistical analysis to say, in Montgomery, is there a relationship between those densities and those violence-related calls for service? And we try to look at things a lot of different ways to make sure we don't come here and tell you the wrong story. And by every way we measured it, there's a positive, statistically significant association. And what that means in real world is it's likely that neighborhoods that have high density of outlets are a cause of higher crime in those neighborhoods. And again, that's not unique here. That is well established. That's gospel, and that's just about religious law all across the country. We have overwhelming evidence of those relationships. And we know it because of those time series data. In some communities, they've done some cool things. They've had some natural experiments and some program experiments where they've gone in and they've revoked licenses from a bunch of establishments in problem neighborhoods. And then they track violence calls. And not surprisingly, when the densities get lower in those communities, the crime goes down. And we also have experiments that show the exact opposite. In neighborhoods where densities are on the rise and where there are more and more outlets opening up so that there's more and more advertising exposure and easier access and more competition among those markets to lower their prices to get it cheaper and make it easier for us to get at. When we see that happen, crime goes up and other problems. So there's a really strong cause and effect relationship, and it gives us an ability to know where and what to focus on. So I'm going to just tell you a couple things that you can think about, hopefully actionable kinds of things, and I'll give you 3 or 4 case studies, just zooming into places in Montgomery. So the first one is, and the first idea here is that there's two basic kinds of outlets that we like to think about. Are they on-premise or off-premise? And on-premises, that's the bar, the restaurant. You go there and you consume on-site, and then you jump in the car and you head home. Those ones are particularly problematic for OWIs. If OWIs and car crashes and injuries is your issue, on-premise establishments, that's the one you ought to be thinking about. The other kind is the off-premise, and that's where maybe you go to the liquor store, the gas station, other place where you can buy it, and you come out with a couple of 24 packs, and you go home or you go to a party and you have your good time. Those ones are particularly problematic for the things I've just talked about community violence. That's really strongly clustered around off-premise establishments. Domestic violence that Cass talked about, where you're likely to have that excess drinking and hitting it really hard, and then you start hitting someone close to you really hard. That's those off-premise establishments. So they give us different effects. They pose unique risks, and we like to look at them separately. So looking at where you have, in this case, your off-premise establishments, and there's a community on the far southwest side of town, and I've mapped there on the right a density. There's a cluster of off-premise. And you can see that neighborhood, the nearest neighborhood there, it's just call, violence-related calls. It's exactly what we'd expect when you have that risk factor right there nearby. So that's a great opportunity to partner with your local police departments to increase enforcement. That might be that you can look a little closer. Is there high risk of underage drinking? Are there any violations of their liquor laws or their liquor licensing? we find in an example like this, where you're going to have a higher number, for example, domestic calls, this is a great place for your Health and Human Services program or agencies, your home visiting, to go in to do a little kind of targeted intervention. You know, in a neighborhood like this that you've got an alcohol risk, when you know with your police data you have a higher number of domestic calls, that's a nice place for your brief screening intervention around alcohol, and your home visitors might do that. That's just a super, right there, low-hanging fruit where you can jump in and make a difference. Another one here is it's helpful to be able to use data like this to identify problem establishments. Alcohol's legal. It's state licensed. But it doesn't mean that everyone that sells in the most virtuous ways. And it's helpful in communities to sometimes just to be on the lookout for the problem establishments, the bad actor that causes problems for the whole community. So, you know, one of the ways you can do that is you can, with your law enforcement, your alcohol law enforcement, you can do that kind of enforcement. Increase the monitoring of those kinds of establishments. When you see those hot spots and calls, you know where to look and you know which establishments to be keeping an eye on. In this particular example, you've got a cluster of establishments just to the west of the university, and that exposes young people to higher risk. And in fact, for many young people today, the college experience is where they develop an AUD, where they get that alcohol use disorder because of that high exposure environment. And communities that can make it just a little less easy for young people, including college kids, to have access, tend to get better lifetime effects. And then the third one is keep an eye out, not just where you already have problems, but let's look upstream and say, can we avoid future problems? So on the lookout for where places where you have density starting to emerge, those hot spots, it was a neighborhood that didn't have problems, and now we're starting to see some. Looking at where you have emerging hot spots, emerging clusters. In fact, there's one that's near the Air Force Base, and that's a particularly concerning one because our servicemen and women are often at higher risk of mental health issues and substance use and alcohol use disorders. So having an emerging cluster right next to the base, it's a recipe for risk at the least. And then one last tip here is I've talked a lot about violence, but it's helpful for communities to monitor more than just violence, because alcohol poses a risk beyond just that. You've got, in Montgomery, you've got this interesting little classification called mischief to property. And when we mapped that in that specific call across the city, and then we looked at it for outlets, you can see some high densities of that mischief call all around the alcohol establishments. And those, as I mentioned, those calls cost the community in real dollars. They cost in sleep, they cost in stress, they cost in higher exposure and higher risk of underage drinking and lifetime health risks, but also safety risks and sense of community. And how strong was that mischief risk? Again, strong, statistically significant, suggesting there's a likelihood that those alcohol density clusters are causing that higher level of call. So I'll let's see here. I'll turn it back over to Cass here, and I'll let her close us out and tell you a few stories.
Okay, so I mentioned that we'd give you a lot of data, and then we'd slow it down and talk for a minute about what can you do with this data, and how can you actually use it. And so that's where I want to be, and we are professors, so I also have questions for you, and I hope that you will play along with me. We've given ourselves a little bit of extra time so I can ask some questions of the audience as we go through this. But we want to tell you a little bit about what else we're doing in Iowa. And this is not to do, if you know people from Iowa, the phrase there is like humble brags. You know, like people are very humble, and so you have to do very humble brags about what are we good at. So I want to do some humble brags, but it's not because we're trying to, you know, be strong for Iowa. It's because the work in these alcohol outlet densities have almost entirely been done in big cities across America. And prior to our work in documenting the alcohol outlet densities in Iowa and across our rural places, you know, Iowa has about 1,000 communities, and nearly 3/4 of them have less than 1,000 people. So when we documented these AODs, we were documenting them for our big cities as well as our small towns. Now, prior to this, the smallest community that had ever been published with one of these AODs had 350,000 people in it. So understanding what's happening in rural places is new. And this is something that the CDC is very interested in. So the CDC, we've been working with them closely, their alcohol team, to understand how can we measure these alcohol outlet densities in rural places. And they have been so excited about this partnership here. And that's because we both are similar in terms of what our populations look like, that there are some very large cities and there are lots of small rural places as well. And that means different things. So we want to tell you what we're doing in Iowa to say maybe this is, we had a 2-year jump start on you. But now we're taking this data and we're starting to move it into action. And we want to show some potential avenues. And then, because we know that when you've worked with one community, you've worked with one community, and when you've worked with one state, you've worked with one state, we want to ask you questions about how you think this will work. Okay, but let me tell you what we're doing. The first thing is we have created, Sean showed you briefly the website that we have where you can go in and actually play with the data, look at any community that you want to look at, and try to understand both where the alcohol outlets are, where those densities are, and then where our great partners in law enforcement have shared data where we can see actually how this is related to calls for service. So we continue to monitor, and we recommend that Alabama also continue to monitor these resources, because as they're there, more and more people start to use them. When we first created our measurements in Iowa, it took a little while to have enough conversations like this to get people to go to that website and start to use that. And now we find more and more people are using that. They're writing it into their grants, to say this is to show that they're in a risk environment and they want to be able to utilize their home visiting services to target that, or they want to get their recovery community center because this is a high-risk environment. So they're starting to use this data in their funding applications and in their ideas for programming. And that starts with monitoring. The next thing is we analyze what we have. And so we've created community-specific analytics and reports. This means on our behalf, we've created 275 community-specific reports in the last year where we just target the communities and let them know what's happening with them and sort of help them understand and explore their alcohol and substance use landscape. And then we partner, which I find so empowering to be in this room right now. This is something that we've really had to work on to create these partnerships between our treatment, our prevention, our intervention, our law enforcement, our communities, Chamber of Commerce, Mayor's Office, and city councils. And we see that in this room, you are light years ahead of us. You're having a conference already where you're bringing all these folks together. But these partnerships with communities to provide training, share insights, and facilitate these solution-driven workshops is the key. I'll show you the next slide. We're going to dig into this in just a little bit. But basically, we go into communities and they get to choose the amount of time, but we do half-day or all-day workshops with folks and say, okay, here's your data. Now, what are your needs? Now, how can we use this data to better meet your needs? And then we just have conversations where we work with them to figure out how to move that data into action that works for them. The next step is we build. So we're creating new measures to identify high-risk areas. We're trying to understand how this looks and works differently in rural places. And Sean shared the main result, which is, surprisingly or not surprisingly, it's working the same in rural places. We thought it might be different, and it has not proven out to be that way. That these densities are impacting families and individuals and communities in the same way that they're impacting families and individuals and communities in big cities like Baltimore and in small towns like Marshalltown, Iowa. And then we've created policy toolkits to better support communities, and we welcome you to come to our website and look at our policy toolkits. We've been working with several national partners to put these together, where you can go in and say, what is the issue that you want to address? And you can get resources and ideas of how you might be able to implement that in your community. But let me tell you a little bit more. So, under Partnering for Change. Now, NABCA, who helped fund this work here in Alabama, has also funded us in Iowa. I said we're a year or two ahead of you on this project. This year, we were funded to create all the data in the past, and this year we're funded to actually go into communities and work with them to use this data to drive change. And two of the examples you see here show how diverse and different the needs are. And we're actually working with 4 communities right now. So in one of our communities, we say, okay, here are your alcohol outlet densities. What are the issues you want to address? And in Waterloo, it's gun violence. Our biggest issue is gun violence, and we see that it is tied to our alcohol outlet densities. And so when we're going into that community, we're working with the mayor's office, the city council, the law enforcement, and then our treatment, prevention, and intervention providers to try and brainstorm ideas about how do we reduce gun violence in the community that's related to these densities. Because the statistics show, and we won't have time to go into them here, that when we look at that call for service data and we look at the alcohol outlet density data, they are significantly linked. And because we have done our database over time, we can see that as more outlets come up, more gun violence comes up. And so now we're working with the community on that. A second community, when we went in and said, okay, here are your alcohol outlet densities, what is the issue of greatest concern to you? They said, well, you know, we have all of our young kids are leaving. No one wants to stay. So we want to revitalize our Main Street. And we have put all this work into it. We've been working on it for years. We're super excited about the new plans. Here's all the renderings. Here's the drawings, blah, blah, blah. It's going to be great. It does, by the way, include 6 new bars and restaurants on our little Main Street. And our sheriff is super anxious about that. And what does that mean for our community? And so now we're coming in and having a facilitated conversation with law enforcement, with the mayor's office, with the city council and the Chamber of Commerce to say, okay, you've already made this decision to increase your alcohol outlet densities. How can you lower the risk? How can you keep kids from coming into these bars and restaurants? How can you provide resources? How can you provide training to the people who are serving to make sure that they don't overserve? And the reason I'm going into these details is to say we recognize that communities are different and communities want to use this data in a different way. And that's part of the goal of Partnering for Change is to actually go in there and ask communities what is their driving and key issue and how can they use this data to help solve it. So we would be so excited to hear about what you have done in the future with this data as we were handing this over to you, and we hope that there is some Partnering for Change involved in there. We also want to be able to improve community-level monitoring of these alcohol outlet densities to inform policy. So this is when we work with our local advocacy groups, this is the thing that they care most about, and these are often our regional groups. And so if you go to our website, you can see we have 3 kind of clusters of information that you can read more about how do you screen and intervene, how do you regulate those clusters, what are the potentials for density regulations, or what are the policy tools for reducing harm? And how can you enforce and train? Once you have a community that either already has these in place, or like our Marshalltown friends is planning on increasing their density, how can you enforce and train people to reduce harm overall through bar checks and responsible beverage service training? And one of the last things that we do when we think about how can you use this data and how do we use this data, now what you see on the screen, I'm going to describe it to you, but what you see on the screen is the same community 4 times. And we have taken this data along with some other data from our treatment episode data set, which is everyone who enters treatment, you fill in your administrative form with your details. And we're looking at where are people from, where we're getting the service calls, and where are people from that are entering treatment. And we're mapping those areas throughout our state. And so in the top left, this is the Substance Use Vulnerability Index overall. On the top right, this is the Alcohol Vulnerability Index. On the bottom left is the Opioid Vulnerability Index. And the bottom right is the Methamphetamine Vulnerability Index. Now, these indexes come from models that we create, and we pull in all sorts of different kinds of data, and we try to predict where is the most vulnerability in this community. And the reason we want to show it to you here is you can see that the vulnerability, like it might be a low vulnerability for alcohol in one community, but this one is particularly high in methamphetamine. And that flips from community to community, what those issues are that you might face. But having this data allows you to target resources. So for all of our wonderful social programs that are trying to address this issue, this also helps you know where to go. So one of the ways that we've used this information, for example, is we've partnered with our public health. And they have a traveling health van that goes into underserved communities. And we've worked with them to know where the vulnerable populations and high-risk groups are in the communities where they're traveling, so they can go and give targeted health resources to those communities. We've also worked with it's called Eat Greater Des Moines, which is kind of like a traveling food bank where people donate food and they drive their van around and give out food. And try and target those resources to some of the most vulnerable populations and groups. So as you think about all this data that you're seeing up here, I will kind of end where I began, which is data is not the answer, people are the answer, and the needs of people and how we can better meet those needs is really the goal that we're coming after. So I told you you wouldn't be off the hook. We have saved our last 15 minutes to ask you questions about what are your big issues around alcohol? Do you see issues with alcohol outlet densities? And if we came to your community and said, what's the issue that keeps you up at night? And what groups do we need to bring together to have those conversations? What would you say? So we are very interested to hear what's happening in Alabama. And these are kind of our open conversations. I'll invite Sean back up. And these are not rhetorical questions. So I'm going to start from the first one. And I'm just going to ask a few folks, what are you seeing? Does this data resonate with you? Do you see a need in your communities for exploring partnerships around the alcohol outlet densities? Yeah. Gun violence. Great. Absolutely. Family violence and child neglect.
What are you seeing in your communities? What are the risk factors? Say again? I think I heard one.
Gun violence all over. Unemployment.
Poverty. What do you got? Homelessness. Seeing that in lots of places around the country. Yep. Good. What else? Sexual assault.
And I heard one back here as well.
To-go beverages. We know that in Iowa. While we were here this morning, one of my policy analysts just texted, and Iowa just moved out of committee. Not only are we allowing to-go service, first in the country to do that, out of committee today was to lower the service age. 16, 17-year-olds in Iowa will soon be able to serve across our restaurants. Yeah.
Absolutely.
Super helpful. What else? Healthcare, health insurance, pressing need, connect people to resources and supports. Good. That sounds like a lot of what a lot of communities we hear in Iowa, and that's just really helpful to know we're not in it on our own, and we're not alone, and that there are some common cause, common solutions. What do you got? You bet.
Yeah,
No, that's just my contact info. But we'll get that to Dean and make sure you get that out. You bet.
And we also have a report that we created for the ABC that we can send out and make available as well, which gives you some of those like key details and data that you can look at on a slower pace.
So the idea here is common cause, common problems, and there are lots of solutions. It's an exciting time. It's a little bit scary. Cass and I are both professors. We teach a lot of young people. We're talking to young people, 18 to 24 mostly, and they're really worried about the future. And the message we try to send to them and we send to you is there's lots of options and opportunities for partnership, for change. Data, as scientists, we think data can help. It kind of cuts through the fog and says, here's a concrete place where there's a problem. Here's a concrete cause and effect relationship that we don't have to debate about and can drive some action. And that there are a myriad of solutions. Sometimes state government can be challenging. Certainly these days it seems like federal legislation is pretty gridlocked. But local level action, that's where these partnerships really matter, because we're sitting across the table and we're talking about the places that we eat, the places our kids go to school, and the places that we live and love and learn and all those things. So local level partnerships around good data and commitment to change, you can get super good action and you can get it fast. Super, super exciting times.
And now I'd ask, do you have questions for us? So we got our questions out. Thank you. Appreciate that. Do you have any questions for us?
Yeah.
What are y'all doing in order to get into, because something that we struggle with is getting into those partnerships with the mayors, with the police officers, especially in rural counties and areas. It's really kind of a struggle when you're like starting out and stuff, because you're trying to make those connections, and there's a little bit of pushback, or there's, oh, we're doing something else, So what do you do when you're faced with that? Hey, we're not gonna work with you right now, or hey, we're not really gonna respond to this right now. How is like some ways that y'all have really infiltrated into the political part of these communities and police officers and things?
It's a great question. I'm going to report back the question, and then do you want to take it?
Sure.
So the question was, how do you get into these communities? Sometimes this is really difficult to make these partnerships, especially when people have their own agenda and they're already working on other things. What's your entryway into there?
Our experience has been is just being out and being involved is a really important starting place, is serving, volunteering on boards where you're going to be interacting with people in different spaces and places, and getting out into those communities. It's one thing to call from the Capitol and say, can you give us your data because we're working on X or Y or Z. It's another to be in the community and developing personal relationships. Developing personal relationships, knowing people by name, getting to know each other, building trust is just really, really helpful. You really do have to integrate people before you can integrate projects, services, and things like that. One other, though, is not everyone's ready. And it is the case that some communities are just going to say, no, we got it figured out here. We don't want or need you around. When we work with communities, we always start with a commitment. Are you committed to change? Are you committed to the partnership? Because time is limited. I'm getting gray, and I think the phrase is long in the tooth, and I've only got a few seasons left. I want my time here to have impact. And I want to commit to in those partnerships where everyone's serious about solving a problem, and not everyone is ready. We've heard that with the substance use stories. Many of you know people who are in the throes of addiction, and they're just not ready for change. You would like to throttle them to change. You'd like to sermonize them to change, and they're just not ready. Communities are no different. Some places just aren't ready, and you cross your fingers and you hope for it, and work with the ones that are.
I'll throw out a couple others. When we first started trying to understand how do you get that initial piece, I mean, we did radio conversations, we talked with news reporters and tried to get it out there. We went out and got money and then said, hey, we'd like to work with you for free. Please call us if you want, and tried to get it out there. And that produced a surprisingly few number of results. Have a website, be in the news, go on the radio, ask people, tell them it will be free. That didn't work super well. But one of the things that we did do is we started making partnerships with local groups. AC4C, which I can't even think of what they're...
in Iowa, we have a coalition of prevention organizations, coalition of coalitions, AC4C. So it's a network of prevention organizations, community-based, county-based, statewide.
And so one of the important things we first did was start working with these coalitions, and then those coalitions would introduce us to local people. And then we've worked very hard that every time we go into a community, when we leave, they are very happy that we came. And then communities ask us to come back. So that's been one of those pathways to success. So I can tell you a whole lot of things that didn't work, but what really worked was working with people. Sean said you have to integrate people before you integrate data. That's become one of our slogans. You really have to get in with people in all of the different ways, and then new opportunities come up. We also work with the League of Cities, who put us in touch with the mayor's offices and things like that. So depending on which group, law enforcement, Sean has done lots of one-on-one phone calls with sheriffs throughout our entire state, making those connections. So it's a lot of knocking on doors and making phone calls. Great question. I saw a hand in the very back.
Hello? Hello. Great presentation, by the way. Good afternoon. Basically, you answered my question. One thing I had, you had am I too loud? It mentioned about a public health van that would go out and monitor high-risk areas. And I guess my question is, I'm with public health, so how did y'all fund that?
So that specific program was funded through one of our health and treatment centers. They provide treatment services, they provide clinical services, and they got a grant that allowed them to build a mobile clinic. So at the local level, we have to get very creative with our funding. Sometimes we get passed through from the state or through federal funding. That's very nice. But as many of you know, at the local level, we're often writing grants to find money to fund those things. But the cool thing on that one, to Cass's story, was this clinic, they got the money and they got a truck. And in Iowa, methamphetamine, you saw about stimulants. Methamphetamine's a big issue there. And methamphetamine comes close with STIs, and it comes close, and often becomes injection. So we had a clinic that had a pile of clean needles and had a pile of interventions, harm reduction interventions, and had messaging about how to get treatment, and they didn't know where to go. They needed a navigator. And that's where a partnership, we're putting the data in front of them, say, here's the neighborhoods where that clinic will get lots of pay and have a strong impact on the community. So that's the kinds of partnerships, kind of creative partnerships. Someone got some money, someone else got a mobile clinic, and then infuse that with data, and you get something cool.
I think we have time for one more question if there are any other questions. Or thoughts. If you have the next big idea, I would love to hear that as well. We can Shark Tank it here. I'm kidding.
Great, thank you for your time.
Thank you very much.
Thank you, Dr. Sean and Cass Dorius. We really appreciate you coming to visit with us today. That was some great information. My name is Daniel Dye. I work with the Alabama ABC Board, and I'm here to introduce our next speaker, Rashawn Blasingame. She's 25 years of being an educator, holds many roles with the Elmore County Public School System. She's currently serving as a special education supervisor, the 504 coordinator, and the school-based mental health coordinator for the county. Her plate's full, guys. During her tenure, she has also served as the director of alternative school, assistant principal, and an inclusion classroom teacher. She received her undergraduate degree at Temple University in Philadelphia and completed her graduate studies at Auburn University. Ms. Rashawn Blasingame, thank you.
Okay, everybody. How many people have heard the statement, I took a mental health day, or I need a mental health break, okay? I'm gonna give you one of those in just a second. If you guys bear with me, probably for the next 30 minutes, I'm gonna give that to you. And the previous speaker just mentioned, data isn't the issue, we are. And I'm so glad that she said that because I'm not gonna give you guys any data. I'm not gonna give you guys any statistics. The next couple of slides are gonna be about me. And that's why my presentation says mental health begins with me. And it's kind of cheesy because mental starts with ME, but I'm gonna share my story about mental health and just talk about how important it is that we bring this awareness about mental health. I would also like to take the time to thank the Hartfields, Mr. Hartfield, for just getting up here and telling his personal story, because it kind of took like the pressure off of me, because I was like, everybody else is coming up here and talking about all this, and I'm about to tell my personal story. So thank you. I mean, I know it was hard and everything, but thank you for sharing your personal story. And you guys, give me a second. I'm going to share my personal story. And even though it says mental health begins with me, you guys are going to become the me, okay? You're going to see exactly how I turn this around and see how it's going to relate to everybody in this room. And I normally walk when I talk, and when I turned that corner and saw these tables, I was like, oh my goodness. And so I might take this microphone off and walk back and forth, but I might just stay right here and talk and keep you guys entertained while I'm up here. So mental health begins with me. There I am. And it's funny because all these other slides were hard to see, and now that I'm showing pictures of myself, they're coming in perfectly clear. But anyways, So these were the good old days. Life was so good. This was when we had homemade Halloween, okay? My hat is made out of cardboard. I had Christmas bows down the front. I had a tutu around my neck. I was a clown, and I was a cute clown. I had those pink and green colors on, and I mean, everything was good. Life was good. Here is also me, okay? And you guys can laugh. I'm so transparent. Hey, this was salt and pepper days. I mean, you couldn't tell me anything. Okay, so some people understand. This was me. This was when my life started to take a change. This is when a lot of people's lives start taking a change. It has been mentioned that adolescence is when we go through a lot of our changes. Adolescence is where we see a lot of the students that we work with go through changes. This was a time in my life when the labels started, okay? I was going through adolescence, and so a lot was going on in my mind, but I was told I couldn't sit still. I was told I couldn't pay attention. I was told that I was gonna have to go into the slower classrooms. And I did. I mean, that's what they told me, and I did. They mentioned to my mom and dad, you might wanna look into some medicine for them. And the only medicine that they gave was a belt and prayer. Some of you guys might be able to relate, but no, I did not take the ADHD medicine or anything like that. We kind of looked over that. That was not for me. We're not going to medicate you. We're going to fix it ourselves. This was also the time that I had individuals tell me I never would amount to anything. They told me to go to trade school, to do hair and nails. I don't know why they told me that, but to do hair and nails, and that I never would go to college or do anything in life because I just didn't have that type of potential. And it was then that something clicked. And I said, you want to bet? I was one of those bad students. I was one of those challenging students. And as Mr. Dye, when he announced me, I was the director of the alternative school, I could relate to those kids because I was one of those kids. I might be one of those adults too, but I was one of those kids. I challenged it. So when people would say, you're not going to graduate, you're not going to amount to anything, you want to bet? Watch me. I graduated. I did not graduate in the top 10, 20, 30, but I graduated. I was able to walk across my stage and look at all the people who said that I never would be anything, okay? During this time, I ran track, and I was a very good track athlete. I had 7 top-notch colleges contacted me. Clemson, Texas, everything, LSU contacted me. They wanted to give me a scholarship, but they kept saying, you know, you gotta up your, at that time, I took the SAT. I was from up north, so I took the SAT, not ACT. And they would say, you gotta get your score up. You gotta do better. You gotta get your grades up. When I took the ACT as it is now, first time I ever took it, I got a 13. And my mom says, come on, Rashawn, you get 11 points just for signing your name. I said, well, I got 2 more points. Let's celebrate. The highest I ever got was a 16. And so all of the college scholarships and everything, they were out there. It was nice or whatever, but I wasn't going to get in, okay? I applied to a college. I applied to the College of Charleston at that time, and I was accepted, but I was under provisionary status. And once again, I got that label. It was like, your provisionary status, you're gonna have to take these courses, you're gonna have to go on this track, you know, we wish you well, probably not gonna graduate, we're just gonna take your money and good riddance. You wanna bet? I graduated. I graduated with 7 degrees. I let those people know, don't stop me, okay, don't. Test me, challenge me, tell me what I can't do. And I share this story because I'm guilty of it, and I'm sure some of you guys are guilty of it as well too. We make those statements to kids, and we don't realize how much it impacts us. And like Mr. Hartfield said, this is my 2nd time ever doing a speech. I did it to a high school during their mental awareness week. They said, hey, can you come talk to us? Yeah, no problem. And then I got a call to say, can you come talk about this as well too? This is the 2nd time I've ever shared my story. So we're learning. Mr. Hart, I'm there with you, we're learning. But I graduated. I post this picture here because once again, this is when my life took a turn for the worse. I was attacked. I was left for dead. I was told I never would be able to have kids. You know, I was gonna have to go into a hospital. In this picture, my eyes were bruised, I had permanent marks on my arm, my neck was bruised, but I put that scarf on, I put those sunglasses on, and once again, I said, you wanna bet? I'm cute, and I'm gonna take this picture. And this picture is going to be my driving force. What took place is not going to stop me. And that was a very traumatic time in my life, and mental health was real, but I didn't know anything about it. But I heard this song, and I'm gonna play it real quick. I heard this song last year, I think it came out last year, I'm not even sure. And when I was listening to the words, that's when I realized I need to get up and start telling my story. Now, technology, I'm gonna see if it will work here, but it might, no, it's not. It's asking me for a code, so hold on, I might do it, might not, but oh, there it is. Just listen to the first couple of verses.
I never held my hand out and asked for something free. I got pride I could roll up for miles in front of me. I don't need your help and I don't need sympathy. I don't need you to lower the bar for me.
Don't lower the bar for me. Don't give me your sympathy. Keep telling me what I'm not gonna do, and I'm gonna prove you wrong. I turn my can'ts into cans, and I turn my dreams into plans. When they told me I never would be able to have children, I had one child, the most amazing child ever that I can sit up here and say. I had to have an emergency surgery afterwards, but I was blessed with one child. That child was a valedictorian of Wetumpka High School. That child has a full ride to LSU. She is in the criminology and law department. And that was one of those, you wanna bet? You wanna bet. So she's making me proud. That's right, clap, that's right. I also have 2 dogs. So sit up here and tell me what I can't have. I'm gonna have dogs too. Jack, my little Yorkie, he's 18. He knows Mama loves him, and he's gonna stay with me this whole time. He has 1 ear, 1 eye, and 1 tooth, but he's hanging in there. And then the other one is Ollie. Ollie, our golden doodle, so Ollie the dolly. This is my family. Without them, I mean, this is my foundation. Even though, you know, I laughed and joked earlier and said my medicine was a belt and prayer, if it wasn't for them, I wouldn't have the drive that I have right now. They were the ones who stood by my side. In that college graduation picture, it was my brother, my mother, and my dad. They were the ones that stood by my side this whole time and kept telling me, keep going, keep pushing, keep striving. These pictures are kind of hard to see, but in these pictures, it's just showing what I have done since that incident when I was left for dead. I am now, I teach teen mental health first aid to some students. I'm a coach, track coach, and personal trainer at a gym in Elmore County. I compete, I love the beach, and I love Buc-ee's. And I started, Buc-ee's. I started laughing this morning because when I was coaching at the gym, I had my Buc-ee's shirt on. I had Buc-ee's Auburn, and I started laughing. I said, yeah, that one university might make legends, but we make beaver nuggets. So if you've never been to Buc-ee's, go to Buc-ee's, get some beaver nuggets, and you'll understand my joke. But everything was good. Once again, life was good. Life was good. So then, here we go. Okay? What you can't see in this picture, the active person that I was a track coach, I was in my 40s, I thought I can sprint with the teenagers, because how dare somebody tell me what I can't do. So I got down in the blocks, runners take your mark, set, and I went, and I face planted on the track. I ruptured my Achilles. I didn't tear my Achilles, I ruptured my Achilles. I learned then that your Achilles runs from your hips all the way down to your toes. I did not realize how important that ligament was in your body and in your leg. I was once again told, you're not gonna be able to do this, you're gonna have to be in recovery for 6 months, you will never be able to run again. Just the damage that was done, never be able to run again, never be able to wear high heels. I had high heels today, they're out in my car, I promise I did. But once again, when I saw these people, I was like, not doing it, not gonna be able to do it. But I wear heels and everything else. And some of those quotes on there, it says, I fell down yesterday, but I stood up today. I don't chase goals. I chase goals, I don't chase people. Tell me what I can't do, Want to bet? So, hold on. So here, these were all within the last 2 years. Montgomery Marathon, I ran in it. Mud Challenge, I competed in it. I am a personal trainer at a gym, and the picture of me doing a handstand, that was taken at Tybee Island this past summer. Do not let my weight or my age fool you, because when they tell me what I can't do, I'm going to show you what I can. So once again, after having a ruptured Achilles, I kept going and kept moving forward. I say all this to say mental health was real. When I left being the director of the alternative school, the superintendent of Elmore County said, hey, I need for you to be over mental health. I don't know the first thing about mental health. That's just something that we just don't talk about, don't even want to think about it. Mental health does not affect you until it affects you. And he had this vision and said, get ahead of it. Come up with mental health, go to all the trainings, do everything that you can, and let's put Elmore County on the map, letting everybody know we're here for mental health. So I said, okay, I don't know anything about it. This is something new, but I'll do it. Yes, sir. When I went to my training, it was then that I realized I was a poster child for mental health. Something that I never knew about, something that I didn't want to know about. It's me, in black and white. Out of the 7 categories of mental health, I have 5 of them. Anxiety, ADHD, depression, eating disorder, and a little transparent thing right here. I don't have the eating disorder where you don't eat. I have the eating disorder where I like to eat. I would eat thinking if I had food in my mouth, people wouldn't come and ask me what my problems were. So there is a difference. You don't have to be anorexic and bulimia all the time. You can overeat, and it can be a disorder as well. And then also with stress and trauma. So all this was going on in my head, and I never knew that this was actually mental health illnesses that I had. They say that 1 in every 5 person has a mental health illness. And when I teach in my classes, I have them count off by 5, 1, 2, 3, 4, 5, stand up, 1, 2, 3, 4, 5. There's entirely too many people in this room, but if I was to do that, there probably would be about 30 people standing up. But if I was to sit up here and say, how many of you guys suffer with anxiety? How many of you guys suffer with ADHD? How many of you guys suffer with depression? That 30 would more than likely turn into 100%. More than everybody in this room would stand up and say, who doesn't deal with stress and trauma? Who hasn't had, some of you guys might not have had an eating disorder. Some of you guys might have ADHD. But this is when I go back to say mental health begins with me. It begins with you too. You guys have mental health illnesses that haven't become a challenge, but we all face it and didn't realize that we faced it. Didn't realize that this is it. The 2 that I don't deal with, and it's amazing that I'm here at this conference talking and learning a lot of new things, I've never had a substance problem, despite everything that I went with in my life. I do like to drink wine every now and then, but it's not abuse. Never had a substance problem, and I never had psychotic thoughts. Never thought about suicide. I do, however, am honored to talk about suicide. And that sounds so weird, but we've got to talk about the topics that people don't like talking about. Elmore County had 2 suicides last month. And if it wasn't for our superintendent already being ahead of the game, he has gone to several different conferences and people have said, you're already there. We couldn't prevent the suicides, but we were able to work with it. We were able to get our community involved with it. We were able to talk to the parents. We were able to talk to these kids. It's kind of like with Dadeville right now, okay? We never know what's going to take place from day to day, and the more that we become aware, the better we are with the situation. And so by me teaching and getting out and stuff like that, it makes it a little bit better and a little bit easier to talk about. Remember I told you I suffered from ADHD, and there was something I was supposed to say just now and I completely forgot, but it might come back to me. But remember I would always say, want to bet. Don't ever say anything is impossible. Don't ever allow your kids to say anything is impossible. The word itself has "I'm possible" in it. Okay? Just like my little quote earlier, turn your can'ts into cans. Let everybody know that they are possible. They can do whatever people say that they can't do. Accept yourself, love yourself, and keep moving forward. Like I said, my family was my foundation, but if it wasn't for the love and the acceptance of myself, and sometimes my attitude, I wouldn't be where I was now. But you've got to accept yourself. You've got to let these teenagers that you guys work with and the youth know, accept yourself. People might not understand the direction and everything that you're going in, but you accept yourself, you love yourself, and then watch how everything else follows suit. Self-love. Self-love will heal you, it will motivate you, it will empower you, and it will restore you. It's not what I heard, it's what I know. It's okay to not be okay, but it's not okay to get help. Okay? It's not okay to stay down there. I'm going to come back and tie something into our cell phones real quick, and then I'm going to close out. But some of you guys had, I went around during lunch, and some of you guys left your cell phones on the table. And I put a nice little card on your cell phone that just says "You matter." Some of you guys got little tokens that said "You're loved" and "You're wanted." It was just a simple, random act of kindness that I did to about 10 people in this room. By you going up and asking people, are they okay, can actually save a life. I don't know if you guys are familiar with the Youth Mental Health First Aid, but Kevin Hines talks about how he is a survivor. He tried to die by suicide by jumping off the Golden Gate Bridge. And he has this long story, and if you guys do not know the Kevin Hines story, look at it. But he says he had it in his mind, he had his plan, he had all this other good stuff. He rode that bus all the way to Golden Gate Bridge. He was crying, he was hysterical, and he says, if one person would have asked me if I was okay, I wouldn't do it. And he said when he got to the Golden Gate Bridge, he's crying, all upset, people staring at him, people talking at him. He got off the bus, he walked down the stairs, he said, and one lady came up to him. And he said to himself, this woman's going to save my life. She's going to ask me if I'm okay. And he said the woman looked at him and said, can you take my picture? And he said, through my tears and through my upset, I took her picture. And she looked at me and she said, thank you. And as she walked away, I got up on the Golden Gate and I jumped. But he said it was that one person, if that one person, and that's the one thing that I want to encourage you guys, just by me handing out a nice little card, somebody might have been having a bad day today. But I'm here to remind you that you matter. This is a cardboard card that you guys can make and just hand them out to random people. The other little wooden tokens that some of you guys got, I got that from Oriental Trading. Start making mental health, start bringing more awareness to it, and start getting more comfortable talking about it. So when we have situations like suicides and mass shootings and stuff like that, we're okay with it, and we can work with it. Okay? Now I want to come back to the cell phone. Why did I put them on top of your cell phones? When I teach my teen first aid, I teach teen mental health first aid. I'm certified in youth mental health first aid, and I'm certified in adult mental health first aid. But when I go and I teach the classes to my teens, I tell them, treat yourself like a cell phone. And I will go around and say the exact same thing to you guys as well, too. If we start treating ourselves like the way we treat our cell phones, this world would be such a better place. If you look at your cell phone, you guys already know I love Buc-ee's. If you look at your cell phone, most of you guys have cases on your cell phone. We put that case on our phone to protect it. Are we wearing jackets on rainy days? Are we wearing jackets when the temperature drops? Are we protecting ourselves? But we make sure that the cell phone's protected. God forbid anything happens to it. Start protecting yourself. If our cell phone messes up or anything, we're so quick to update it or run to the AT&T store and get a new phone and different stuff like that. What happens when you guys break down? We need to start taking mental health just as serious as our physical health. You go to the doctor when you have a broken arm. We need to start going to the doctor when we have mental health issues. I would tell my kids in the classroom, look at the percentage that your phone's on. And a lot of these kids would have their phones plugged into the wall. A lot of these kids would have portable chargers, and they would say 75%, 86%, 90%. There never was anybody in that room where their cell phone was less than 50%. And they were proud about that. But then I would turn around and ask them, what percent are you on? Your cell phone's at 90%. What percent are you on? Well, I'm on 20. Well, I'm on 10. I didn't get much sleep. But we're making sure that this is charged up. Start charging yourself up. So we said, protect yourself like that case. Charge yourself up like you charge your cell phones up. Give back. Start putting your cell phones down. Start looking at the people across the table from you. Start talking to the people in the house with you. As much energy and effort that you put into your cell phone, put that into the people that you guys care about. Cell phones have taken away our family values. There are photo albums, there are communication, there are notepads, there are credit cards. Go old school. Don't have me pull that picture back up of me and my salt and pepper hair, but take it back to those days, okay? Disconnect and reconnect. And this is funny that I have this up here and then I can share my story. Like I mentioned a few minutes ago, Elmore County had 2 suicides. I'm the type of person where I want to fix everything. I want to know. So when we were out talking to these kids, and Miss Jackie's in here somewhere. She's still here, Jackie Taylor? Oh, she's back there. We were going out and we were talking to these kids. And some of this stuff that these kids were telling us, you would think it's stuff that you would hear on TV or stuff that you would see on shows. Kids telling you that it didn't bother them. I went and saw the dead body. This is what she wanted. She was tired. This isn't the last one that's going to take place. Don't pray for me, I don't believe in God. These are the things that these kids were bold enough to tell us. And you guys, I broke down. Never once. Me, bad old, big old me, would break down. I broke down to see kids sitting across from me telling me some of the stuff that they told me. And to know that these kids would say, this isn't the last one, it's going to keep on happening. So in my mind, I wanted to fix it. I wanted to be the next person to stop it, to get out there and get it done. And I realized I was at 0%. The things that I teach my kids, make sure you keep your, level up. I was at 0. I couldn't do anymore. People were calling me and asking me what to do. Guys, to get a call from your superintendent 2 Sundays in a row at 7:15 in the morning and say that we've lost another student by suicide, I couldn't take it anymore. So I had to disconnect and reconnect. I called Carnival Cruise Line. I booked a cruise. I cruised out of Charleston, South Carolina, thinking I wouldn't know anybody on that cruise. And I went on a 5-day cruise with no cell phone or anything. And I told myself, if anything was to take place while I'm gone, it will be okay, and I will handle it when I get back, because there's not like I can do anything right now. And I got on that cruise ship by myself for 5 days. And when I was back, I had that you want to bet attitude. Got back out in that community, coming speaking to you guys and everything. But I had to disconnect and reconnect. And as the one thing says right here, almost everything will work again if you unplug it for a couple of minutes. And that includes you. Unplug yourself. Turn the news off. We're hearing all this stuff about Dadeville, and people are like, I don't want to let my kid go. I've canceled my 16-year-old's birthday party. Disconnect every now and then. Don't forget about it, but disconnect, because it's going to affect your mental health. So going back to the title of my presentation, Mental Health Begins with Me. I hope by me sharing my story and bringing my awareness to you guys and being as transparent, it's now letting you guys realize it starts with you. You have become the me. You guys need to get out and make mental health more comfortable, more something that we want to talk about. Talk about it every day. Like I mentioned, I teach teen mental health first aid, I teach youth mental health first aid, and I teach adult mental health first aid. I tell everybody, if you go around and get CP certified, you need to go around and get mental health certified as well too. okay? I will make myself available to let you guys know if you guys need for me to come out and teach anything to you. I can do that as well too. And as of this morning, I'm also getting certified in this QPR, which team mental health and all that, it's a 6-hour training. I think QPR is now like a 45-minute training, so I will be certified in this as well too. And I have no problem getting out and sharing my story and sharing my knowledge and making mental health more comfortable, more of a topic that we need to talk about more. Don't talk about it after something happens. Talk about it before and be ready for it. My last slide, and I don't know, am I overtime, undertime, but I'm almost done. My last slide right here. I messed up. Here we go. Right here. I don't know you guys. I might know 4 people in this room. But when I say this, I mean it. And I want for you guys to go out and say it more often and mean it more often. But I love you, and I mean it. We need to hear more of that. And I appreciate you guys and what you're doing, and thank you for letting me share my story. That's it with me. Thank you. Thank you again.
Don't go anywhere. I want
Okay.
you to draw for a door prize.
Okay. Yay, thank you. I didn't go over, did I?
No, you're perfect.
I'm drawing my name. I'm getting that TV. I'm drawing my name. Shaking it up. Here we go. Oh, glory. God.
All right.
It's not my name.
How about Suzanne Reagan?
The one that's sitting right next to me.
Suzanne Reagan.
You won! Yay! Congratulations.
You can give that to her.
I sure will.
I want you to draw one more.
One more. All right. This is my name. For real. That might be 2.
That's 1. It's 2.
2.
Tommy Stewart. Not here?
Not here.
All right. Ansley Ricks.
Yay! No? Yay? Oh, she's going to do it. Thank you.
Thank you. Let's give Rashawn another round of applause. No, thank you. I don't know how many times you say, or you've heard your coworker say, I'm tired. I'm worn out. The challenges that we face are just insurmountable. I don't know when we're ever going to get the resources that we need. We say that all the time, all of us do, because we're so passionate about what we do. And that's why I was so glad that Rashawn was able to come and share with us today, because of what she's been dealing with, especially in the last month and a half since the 2 students at Stanhope Elmore took their own life. It was a great impact on this community and the community in Millbrook and in all of Elmore County. And we're guilty sometimes of thinking that we're the only ones that are facing the challenges that we're facing. And what was just asked out in the lobby, the fact of the matter is that everybody in here now should know somebody new, so that when you find yourself in a position to where you feel as though that you're being challenged, or you're going down the wrong road, or you're just going to have to give up because you're so tired, you now know somebody who's in that same boat with you, can help you get water out of the boat just as fast as you're paddling to get it out. So let's make sure that we take advantage of all of the friends that we are making today and that we have in this room, because that's the thing that we need to remember when we leave. None of us are in this by ourselves. None of us. All right, it is now almost 2:15. Let's take a 20-minute break. Let's come back in here at 20 minutes till for our last presentation, which you're going to love, and then of course we'll have some more door prizes. So enjoy your break. All right, before we get to our last panel for the afternoon, Miss Robin, can I get your help? Would you draw me a name, please? Don Campbell. Dr. Baron Sandlin. Is Dr. Sandlin still here? All right, there he is. I'm privileged to be able to be part of a school-based education program called Underage Under Arrest, where we go out into schools and talk to young people about the dangers and consequences of underage drinking and other substance abuse. And one of the things that I do to start my program is I ask a question. And I need you to raise your hand. Don't scream it out. I'm going to tell you just like I tell the kids. I'm an old guy, I don't hear very well, and if you scream it out, I won't hear you. But if you raise your hand, I will know that you want to talk, and I will ask you to give me the answer at that point. So here we go. Raise your hand if you know the answer. You don't know it, Courtney, don't raise your hand yet. What is the most used and abused drug in Alabama? Tobacco. That is so close, but that's not it. I said, don't holler it out, I can't hear you. Not vape. THC, that's not it. That's not it. Alcohol. Alcohol. The most used and abused drug in Alabama, not only in Alabama, but also in our country. And I know that you know, as we go around and talk to people, that alcohol, at least when I was growing up, was the original gateway drug. And our young people are 5 times more likely to become addicted later in life if they use alcohol prior to the age of 21. But as we travel the state, we always go to the principal prior to our program. And we ask the principal, what is your number one issue? And overwhelmingly this year, the number one issue is vaping. I'm going to be honest with you and tell you the truth that just up until a couple of years ago, I didn't even know what vaping was. I didn't know what Juuls were. My 16-year-old son had to educate me on what a Juul was. But we're finding out more and more that our schools are being overrun by vaping. And then the question is, where do they get it? And how do we combat that, not only as concerned parents, but as a concerned community, as a health community, as a law enforcement community, as a social worker community? How do we combat that? Well, I won't say that we save the best for last, but what I will say is, I am so proud of this segment that you're going to hear so many examples and ways that our young people are finding to get their hands on not only vaping, but also tobacco products in general. So I'm so proud that the 3 folks behind me are going to take us home, so to speak, this afternoon. We're going to have an opportunity to let them present, and then we'll have an opportunity to ask questions at the end. But I'm so proud of these 3 folks. I want you to give them a big round of applause, and we're going to start with Miss Robin.
Hi, everyone. So as you know, vaping is a huge and growing problem, and it's affecting every corner of our state, every high school, every middle school, and even most elementary schools. So what I'm going to go over, basically the basics of vaping. I know some of our speakers have touched on some of these topics, but I'll go over the basics and what we're concerned about when it comes to vaping in kids. So first of all, these devices were created to help adults quit smoking cigarettes. The irony is nobody can quit these devices now. And part of that is because nearly all of them are flavored. There are tens of thousands of flavors of vapes available on the market. And most kids report that they vape simply because they like the flavor. And nearly all kids are vaping flavored products. So that's driving the vaping crisis. They also go down easier than cigarettes. They don't burn. That's helping drive the vaping crisis. But we are really getting away from calling them e-cigarettes. They have come so far from cigarettes. In fact, most of them now, they're made with nicotine salts and synthetic nicotine and aren't even derived from tobacco. And that's one problem we're having, is because these are still embedded in our tobacco laws, the regulations on these. But a lot of them are not tobacco products. And on top of that, they're used for so much more than nicotine now. We know that they're used for THC, for hemp-derived products, and for synthetic drugs. And they've evolved. They constantly evolve. Like Dr. Harris was talking about dietary supplements earlier. And he said that our lawmakers will pass legislation, and then these products will just change one little molecule or one little piece of it and get around those legislations. So vaping is doing just that. These products, these devices, they're evolving, and our lawmakers are a little bit slower at catching up and passing legislation to regulate them. Once they do, the vape industry modifies the product just a little bit and gets around those laws. So they're constantly evolving, different shapes, different sizes, different colors. There's pre-filled, there's refillable, rechargeable, single use. But the common thing is they all have a battery, a heating element, a mouthpiece, and a reservoir. And that reservoir contains an e-liquid. So there are problems with the e-liquid itself, regardless of the drug. One of the biggest concerns is these e-liquids are made primarily of propylene glycol, also vegetable glycerin. Then they throw in the drug and the flavor. But propylene glycol, when it's rapidly heated in these devices, changes properties, changes its chemical state, and produces byproducts. So what goes into the e-liquid is not necessarily what's inhaled in the aerosol. And the byproducts, there's a list of a few of them. There are hundreds that are found in the aerosol of the vape devices, but formaldehyde is a byproduct of propylene glycol. Propylene glycol is in pretty much all e-liquids. It's what lowers that temperature and allows it to be inhaled at a lower temperature. So our kids are inhaling formaldehyde, acetaldehyde, arsenic, acrolein every time that they're inhaling. Another problem is that chemicals can leach from the device itself into the aerosol. So heavy metals, chemicals from the battery can leach into the aerosol that's being inhaled. And the e-liquids are not tested for safety. So the FDA is a little behind the game. Basically, these products can go on the shelf before they're ever tested, before anybody looks at their application with the FDA. So there's a lot of unsafe things going on with the e-liquid itself, aside from the nicotine, aside from the drugs. Other things that are found in the aerosol of the e-liquids, pharmaceutical drugs, and I don't mean the recreational kind, I mean like heart medications have been found in the aerosol that's inhaled. Toxic additives. So we mentioned earlier outbreak of EVALI, the vaping-associated lung injury. A couple years ago, there was a huge outbreak that hospitalized thousands of people, caused dozens of deaths, including here in Alabama. That was later attributed to vitamin E acetate that was being added to THC e-liquids. So we don't know what's being added, especially when they're obtained illegally or informally. And then we have that risk of toxic and potentially lethal drugs being found in our vape devices, fentanyl, synthetic marijuana, which can make our kids really, really sick. So nicotine, when we're talking about vaping, generally we're talking about nicotine. So the nicotine has changed over time. It is not the nicotine that's in cigarettes. The nicotine in cigarettes is free-base nicotine, but they have developed nicotine salts and synthetic nicotine to use in vape devices. Juul is responsible for the nicotine salts. They're all but bankrupt now, so kids aren't calling them Juuls anymore. They're not using Juuls, but they were responsible for really evolving these products. But the new forms of nicotine are absorbed much more efficiently in the body, much quicker, and in higher doses. So the kids are getting much larger doses of nicotine than if they were smoking cigarettes. So we know nicotine exposure increases the risk of addiction. That's our biggest concern with nicotine, is the addiction. But it also increases the likelihood of future addictions, because our kids are going through processes in their brains where they're pruning out pathways that are not being used, and they're strengthening pathways that are being used. It's called myelination. It's strengthening those neural pathways. So if a neural pathway is using nicotine, it's strengthening, and that's permanent. So in the future, if they were to take up another substance, that pathway in their brain for addiction is already there, and that substance can sort of jump on board and cause addiction much quicker, raise the risk of addiction to other substances in the future. Nicotine also is causing memory and concentration problems, worsening ADHD symptoms. It's causing new and worsening anxiety and depression, and those kids are more likely to use cannabis. Kids who vape are more than 3 times more likely to use cannabis within the next year. And another concern that we have with nicotine e-liquids is it can be potentially toxic or lethal for young children. So these products are flavored, they're scented, they smell like candy, and if small children get a hold of them, they don't know what's in it. They drink it, it can be lethal. We're seeing a lot of emergency room visits of small children who are getting a hold of these products. Even if it's spilled on their skin, it's absorbed through the skin. So that's a big concern. We do have packaging laws here in Alabama that require these products to be child-proof packaged, but we know that teenagers are not very responsible. So once they get a hold of these products, they don't necessarily take the responsibility of keeping it out of the hands of the younger siblings or younger kids. And then there are things that we still don't know about these products. There's a lot we do know about the chemicals, but there's a lot we don't know. For instance, vaping weakens the immune system, and it does that by reprogramming some immune system cells. So we don't know long-term if constantly doing that is going to lead to more cancers or more autoimmune disorders in the future. We also don't know the effects of, the long-term effects of exposure to the extremely high nicotine levels that kids are getting, especially on brain development. And then lastly, we don't know what these chemicals do if they're inhaled over and over and over. So formaldehyde, for instance, prolonged exposure to formaldehyde increases the risk of leukemia. We don't know what the long-term effect is of constantly inhaling formaldehyde. And then to get on with some of the other drugs that are used in vape devices, marijuana concentrates are used in vape devices, and the concentrates that are used are extremely, extremely, extremely potent. So the dried plant product, dried marijuana, typically has THC levels of 5 to 20%. 20% would be a very, very strong marijuana. The concentrates typically have THC levels of 40 to 80%. I've seen as high as 90%. So it's really exacerbating those risks of marijuana use, causing intense nausea and vomiting, making kids very, very sick, even with one puff. Hallucinations, paranoia, panic attacks, really raising that risk of marijuana substance use disorder, psychosis, which they're seeing more often among people who are regularly using these products, and newer worsening anxiety and depression. And then marijuana is illegal in all forms in Alabama. It's illegal everywhere for kids and teens. So if they're getting it, they're obtaining it illegally and informally. And that raises the risk of spiked products and toxic products containing synthetic marijuana or fentanyl. Because as we know, drug cartels, drug dealers, anybody who's selling these drugs doesn't hesitate to replace one psychoactive drug for another in order to make a profit. So even if marijuana comes from someplace where it's regulated, it's trucked here illegally, it's cut, it's mishandled, somebody's trying to make a profit. So they might add in other psychoactive drugs to make money. And then we've got our hemp-derived products. So this is a huge growing problem in our state and everywhere in the country. And these products, again, carry higher risk of being spiked or having toxic additives in them for a number of reasons. These products are essentially synthetic drugs. So even though they're considered derived from hemp, they're not actually made from the hemp plant. Drug manufacturers are getting CBD, which is legal, through the Farm Bill, and they are using chemicals and household chemicals and solvents to do a chemical conversion where they extract the Delta 8, Delta 9, Delta 10, HHC, THCO. They're extracting it from the CBD, converting it from the CBD, and making these other psychoactive drugs out of it. So that can pose risks. If they're doing that not very carefully, those solvents and household chemicals can leach into the e-liquids. And this industry is entirely unregulated. It's legal through the Farm Bill because the Farm Bill allows for hemp production. And so drug makers are finding these new compounds that they can get out of the marijuana or out of the hemp plant through these secondary processes. And even, like Mr. Hatfield mentioned, even products sold in stores have been found to contain fentanyl. And that's really because this is a completely unregulated industry. The FDA is not overseeing this. Nobody is overseeing safety. And long-term risks of these is still really unknown because it's only been in the past couple years that these have emerged, that the hemp has been legal and drug makers have found ways to extract new psychoactive drugs out of it. So we don't know what it's going to cause long-term. We don't know with kids what happens if they're using Delta 8 long-term or THCO, which is synthetic. And unfortunately, because hemp is legal and because these are technically derived from hemp, these drugs are allowed to be sold to and possessed by minors in our state. So that is really driving the vaping crisis. It's causing lots of problems for law enforcement, determining what kids have before they can actually act on it, because some drugs they can't cite them for it. It's legal for them to have and possess. But the common thing about all of these drugs, nicotine, marijuana concentrates, all of the hemp-derived products, and synthetic cannabinoids, is the device itself. They're primarily used by young people through vape devices. So with that, I'll turn it over to Mike Cook.
All right. Before I get started, I got to know who I'm talking to. Law enforcement. Show me how many law enforcement we got. Counselors. Judges, attorneys. How many parents we got in here? Grandparents. Keep your hand raised. Out of all those jobs we talked about, that's the toughest job in the world right there, is raising our kids. Now, what Robin told you, it's all factual. But I'm going to talk old school to you, and I'm going to just talk common sense. That's what I'm here to talk about. I'm 56 years old, and I grew up old school. My dad told you once, and the second time there was consequences because he had to talk to you again. Now, I don't know if any of y'all grew up that way, but if you did, you know what I'm talking about. Mr. Lundy, I see you back there. You bailed out on me. But I'm sitting here and I'm listening to Robin, and I listen to everything we talk about, and Delta 8, Delta 9, Delta 10, nicotine, not nicotine. What does it matter? What does it matter what they're smoking? We have got to get to a point, because there's a Montgomery sheriff's deputy back here. Where's he at? Herb Lundy back here. They want to do their job. ABC. I was 30 years law enforcement before I retired. Thank God I made it. And then I come to work for the Drug Education Council. Well, laws were a little bit different when I was a little bit younger. And, you know, when I started, we had a flashlight and a set of handcuffs and a gun. That's all we had. And now I see you poor officers, you look like you going into Afghanistan. You got bombs and grenades and everything on you. And you know, I want to run and hide when you come in the store, and I'm one of you. So, but we spend all this time talking about, I can't do this because this is what's in the liquid, or this is, if it's got marijuana in it, it's got to be tested. Why? Because if we can get to the point, when I was the police, if you were standing there and you were holding a beer, now I know this ain't a Bud Light now, this is a beer, okay? If this is a beer, it didn't make no difference if it was 5% beer, 10% beer, or 1% beer, it's against the law. If you're under 21 and you holding it, it's against the law. Period. That's the end of it. You holding it, you're under 21, you go to jail. That's the end of the story. We have got to get it to save our kids where if you're holding this and you're under 21, it's against the law. I don't care if you're smoking orange juice. I don't care if you're smoking nicotine. It don't make no difference to me. If you've got this, you have broke the law, and you need to let them gentlemen do their jobs. So we got to have somebody that says, we don't care what this is, whether it's nicotine, I don't care what it is, if it can go in this, and you're holding it and you're 21, it is against the law. Period. There don't need anything else said. That needs to be the end of it. So my buddy John Gamble back there in the back of the DA's office can go, you're guilty, you're 19 years old, you had this in your hand, next case, move on. So that's where we got to get. But we have made it so easy now and you know, Robin said something a few minutes ago, and again, I'm going to dumb it down for you. I'm just an old country boy. You think about a 17, 18-year-old cannot walk in the service station legally and buy nicotine. But he can walk in that vape shop and buy Delta 8, 9, 10, whatever, and be legal because there's nothing against the law for it. We don't have anybody that regulates that. Nobody looks at that. But that 19-year-old cannot buy nicotine, but he can go in and buy that Delta 8, 9, or 10. Now, you think about that. We're backwards on that somehow or another. And, you know, it all comes down, you know, we started out with real big vapes and Juuls, or vapes, that, you know, they were about that big, and you can either knock your boyfriend in the head with them or you could smoke them. And if you pull up beside the car, you would bust the window out because you think the car's on fire. Okay? But they continuously make them smaller and smaller and smaller. Well, again, I'm 56. They can make it big as the back of the truck for me because that's legal for me. But they make them about this big now, or a little bit smaller. For who? For the kids. And now, I've just got 3 right here. I've got strawberry cotton candy, sugar cookie, and cotton candy orange. Well, I don't know a 56-year-old man that wants to smoke no sugar cookie. I'm just telling you, I don't know one. Okay? So who are they making this for? They're making that for that kid. They're making it for your kid, for your grandkid. And, you know, boy, Reverend Cook fitting to get on the pulpit right here, boy. I'm just saying right now. All this, there's a lot of things I wanted to do when I was growing up, but I didn't do because my daddy had time out, and the time it took for him to get that belt off and get on my britches. Now, I'm just telling you, a lot of these problems start at home. We got a lot of people and parents. You know, there's two things that I can tell you for sure. That a parent cannot be a parent and a friend. He's got to make a choice. They have got to make a choice what they want to be. Because if you're a friend on Monday, they're going to expect you to be a friend on Wednesday. They want you a friend on Thursday. But if you're a parent on Monday, they're going to know you're a parent on Wednesday and Friday. And that is what we got to get back to. But, you know, when they first come out, $40, $50 to buy one. Now you can go buy this puff bar right here for about $7. You get 300 puffs on it. They take it to school all day long and sell it for $5 a puff. Now, I ain't no mathematician. I just did make it through math, but somebody making a lot of money. And, you know, we just come out of COVID, and everybody wore a mask, and they, you know, couldn't be around anybody, but they'll pass this around and at break, and everybody's hitting it. And then you wonder why we're still getting sick. But it all comes back to bad choices have bad consequences. Now, I have this little nasty bag, and I don't know if all y'all can see this. Do y'all see that brown, nasty? Okay, can all y'all see that? Now, I want everybody to do me a favor, because you know, our children know more than we do. Ask them. And it wasn't like that when we grew up. Yeah, it was. Yeah, it was. Now, there's a lot of things. Now, I will give it to the kids today. There's a lot of things out there that we didn't have to deal with. But we still had to deal with them things, and we still had to make a choice whether we're going to do it or whether we don't do it. But this right here, I want you to look at it because, you know, all the kids, they ended this thing that vaping and juuling is better for you than smoking a cigarette. Anybody believe that? That it's better for you? Oh, Lord. Okay. To prove to you what I'm talking about, I want everybody to take a deep breath and hold it. Now let it out. Now this time, everybody take their vape and put it in their right hand. Everybody hold their vape, hit it, and hold it. Now I want you to let only the bad stuff out, not the good stuff. Cannot do it. You cannot do it. And everything you take in, you do not let out. Because if you did, you're what? Come on. I know it's late. You're dead. If you run out of air, you're dead. So if you let all that air you just inhaled out, you're dead. So that proves to you that you can't let everything out. And that liquid that you're bringing in, this is what that little bit that sticks to that lung right here. Now your body will repair itself. I don't care, anything in your body will repair itself except the lung. If you walk down a split rail fence and you get a splinter in your finger, you don't do nothing to it, what's going to happen? It's going to get infected and it's going to push it out. Mr. Lundy goes out on Friday night and has a little bit too much to drink. What happens to Mr. Lundy? He gets to feeling sick and he what? He throws up. Why does he throw up? Because your body's saying that ain't supposed to be in your stomach, I got to get rid of it. But your lungs will not. Whatever happens to your lungs today, you will have to the day you die. Now, I'm not telling you if you're a smoker or you're a vapor, that if you quit that you won't breathe better and do better. But whatever damage you have done to your lung, it will not repair itself. And I can talk to you about that because I lost my mom at 65 years old to small cell lung cancer. I'm the one that sat beside my mom in the doctor's office when they said, Miss Cook, you have two choices. You can stop smoking, you can watch your grandkids grow up, or you can continue to smoke and you will not. Now, I stand in front of you. I love my mom. She gave me everything I needed and a lot of things I wanted, but she took option number 2. She did not get to see her grandkids grow up. When me and my sister went to the house to clean it out the last time, my mom's life was an oxygen tank line. Ever how far that line went, that's where she could go. I went and got the oxygen tank, went to dragging it, and there was a little pouch on top of it. 3 packs of cigarettes and 2 cigarette lighters on top of that oxygen tank. That's how bad nicotine had my mom. But my mom would look me and tell me in the face every day she could quit anytime she wanted to. And if you don't hear anything else I tell you, please don't let your kids tell you it's just nicotine or it's just marijuana. It's never just. It's never just. And everything we do always starts with one. Always starts with one. And whatever we do that one time, we go right here. And for the rest of our life, we try to get back right here, but one will never do it. It always takes 2 or 3 or 2 of one and 1 of something else. So we've got to break that curve, and we've got to get our legislators, just like she talked about, we got to get some laws changed that we don't care what you're doing with it. If you're holding this right here and you're not 21 years old, then you broke the law. Do your job. All right? I'm going to let Mr. Reese talk to y'all now. Thank you.
Dang it. That's pretty powerful. It's an honor to be here again, and it's an honor to follow both of them. And I always imagine I'm Elvis. Somebody said, actually, my grandmother said, when I was a little boy, she honestly said this, "You're a pretty boy, but you're not Elvis Presley pretty." Liar, liar, pants on fire. Everything that Robin and Mike said. I'm going to talk, and I only have a short time because we got to get you out of here and get you home. But we're under attack, and exactly what Mike just said is 100% true. This is the Alabama Says, and what that stands for is Substance Abuse Youth Summit, correct? How many kids do we have in here? Thank you. See, everybody in this room made a choice to come here for a reason, and I know it's for the right reasons. And I know so many of y'all, and I'm so grateful for your long friendships because we've been in the battles together with all this. But what we've got to do is, when we hold this summit, we need to have the 130 that's right down the road in here, and they need to hear all this. They need to hear Mr. Hatfield and Mike and Dr. Madross, and they need to hear the damage that is being done to our kids. They need to see the wave that's coming, and see, it's not going to take place down there. It's going to take place here. And the ones of y'all, when you see this, it'll piss everybody off in this room. That is the wave. That is the future. And if we stand by and you don't get mad about it and stand up and do something, see, we fight it every day, but we're tired when we go home. And what we got to start doing is making phone calls and contacting legislators and just say, we're not going to tolerate this crap anymore. Enough is enough. Mike hit it on the head when he said this. It is a crying shame that a 5-year-old kid can walk into a store and buy CBD. 5-year-old, and you say, well, nobody's going to sell a 5-year-old. Believe me, there are people in this state that would sell a 2-year-old. They don't care about anything but one thing, and y'all know what that is. But when you see this, or Mountain Dew, hard Mountain Dew, that is the wave. And we've got to do something about it right now. Now this is one, in my whole life, I've never drank a Fresca, ever. And they probably have got this, somebody said it tastes like cow urine. So they probably improved that one, right? So, but what my point to y'all is, who are they marketing them toward? Just like Mike said, they're not for us. Y'all know that. You know who they're looking at, and they know where the market is. They know. See, these are not alcoholic drinks. These are vapes. Those are the pods that you can put into the vapes, and they're not targeting me. They're targeting our kids. And it's time, when we see this, for us to all band together and just say, look, that is the truest statement that you're going to hear. We have gotten so accustomed to being lied to about all of this stuff that it's time now we finally say, how much is enough? How much? You know, knowing the truth and seeing it and letting them still feed it to us and us accept it, and that's what they do all the time. It's time to stop. I mean, we've got, when I saw this, I busted out laughing. When they got on them real good, this guy that was over Juul said, I hope we didn't do anything to mislead people into thinking we were trying to sell them to kids. They advertise on the Cartoon Network, Nickelodeon, they followed the playbook, just like Big Cigarette did back in the 50s. Look at that. Those are Juul pods. That's Marlboro. I have hundreds and hundreds of slides just like that. They just recycle everything, and they shove it down our throats, and we willfully go along with it, even to the point where they had a doctor on the television in the 50s that said, I can recommend cigarette smoking because it helps people calm their nerves. They did the same thing with the Juuls, with the pods, with the off brands, where they had the same kind of ads where they put doctors in white coats and said, hey, the benefits. And everybody in this room knows there's no benefits. In fact, did y'all know that not one company, when they invented vapes, not one company ever went to the FDA and registered it as a smoke cessation aid? Liar, liar, pants on fire. And what were the people doing to cause that? Nothing. The Chinese batteries, lithium-ion batteries, is what just overheated like the hoverboards. This is what they're giving us. This is what they're telling us. You know, if you want to ban smoking and all, we're going to fight y'all, because they have the money to fight it, because they're making so much money off of it. See, in my long career, I've probably stayed way too long, but I'll say this. There's always been trends that come along, and as soon as you see them, you think, that's not really going to be a good thing. But I remember when vaping first came out, and somebody asked me about it, and I went, we had worked, because I worked with the ABC board, so hard getting smoking rates down, and it was paying off all across this country. And now look where we're at, skyrocketing again. We have people that almost lost their lives. And the FDA did nothing about it. Finally, 4 years and like 8 months after nobody applied as a smoke cessation aid, and Juul was off and running. They had 80% of the market. Finally, the FDA stepped in and said, well, you know, maybe we ought to take a look at this and see if we can get it right. So what they did is they said, why do people vape? They vape for the flavors. Alabama is third in the country with the number of people vaping, adults and kids. 9% of Alabamians vape. It's not high school. It's not middle school. It's all the way down to elementary school because of that. Somebody said that is the Apple of the vapes. And that is wrong. 2 packs of cigarettes is what it is. 1 pod is the equivalent of 2 packs. And there are some of the vapes that's the equivalent of 4 packs of cigarettes. We got to do something about it. And I know when they say, well, we're going to change it, we're going to make it harder, we're going to do away with the flavors. So 2019, they decided to do that. So what they did is they banned the flavors except for one thing. Disposables. One-hitters. They said one-hitters can do it. So what does that mean? What would you think if you heard a one-hitter? Well, hell, Mike, even you know the answer to that, right? You said you're not good at arithmetic. A one-hitter should be a one and done, right? E-cigarettes, it just flew off the shelves because kids went to this. That is a one-hitter that had 400 puffs, 5,000 puffs, 6,000 puffs. And the FDA said this, well, by the color of the law, yeah, they're skirting it some. See, my thing would have been if we'd have had a strong FDA, what they should have done is said, okay, we gave y'all an opportunity and y'all blew it, so we're just banning all of it. Are they ever going to do that, though? Never. But they came down on Juul last year and said, y'all are not really good citizens, so we're stopping y'all. And then they filed a countersuit, and then the FDA said, don't sue us. While we think about this, y'all submit some paperwork. So is Juul selling today? Absolutely, they are. While the appeals go on and on and on, and more kids. And this is what kids want now. It's like Robin said, they don't care about the Juul pods anymore.
Did you eat straight?
I mess with this new Killer Kush, bro. It's liquid. They call it bubbly. It's the new weed that just came out. Pure THC. Wanna hit it?
Bro.
See what color it's right here. It's right in there.
Is that Pepsi? Bro, D.
That's that new
What is you
weed.
looking at, man?
That's that. Let me hit this, bro.
I mean, like, give yourself a chance to breathe.
Hold on, man. Hey, hold on, man. Hold on, man.
Hey, dude, chill, man.
Get on me, man.
Hey,
my hair on fire.
man.
My hair on fire.
Bro, you chill, man. That ain't nothing but a vape. That ain't nothing
My
but a
hair on
vape.
fire.
That ain't nothing but a vape, bro. That ain't nothing but a vape.
Was it weed? Of course not. Everything that they buy in the stores is synthetic now. You know, that's the other thing, and I'll get to it hopefully in a few minutes, but the thing with what they are wanting now, they want the pods that have the weed in it, and by the way, this is what happened in a short time. We started in 2019, all of a sudden a lot of kids getting sick with lung disease, and then they started dying, including here in Alabama. We lost our first, I think, at the end of September 2019. We had 15 cases here in the state that they were watching, and then all of a sudden, they decided to name this thing, and it was called EVALI. So after they named it, and all these kids are continuing to go to the hospital, unable to breathe because of the damage they were doing. And like Mike said, what goes in stays in on this stuff. The damage that you do is irreparable. 17-year-olds with double lung transplants. They attributed all the deaths at that time. They said, they came back and said a common denominator is when they use the marijuana pods, vitamin E acetate. And women, y'all use vitamin E acetate every single day. In makeup, it's in food products. But for some reason, when they superheated it in the pods, it's what caused the deaths. But not every death. See, the jury is still out on that, but it was the bootleg pods that were killing kids. Now, where would it come from? Alabama. Where would we get these kind of pods? Well, Aaliyah did a magnificent job on the interstates over in Greene County. But who are these kids? How do they get them on the street? Well, they take them off the highways and they sell them to our kids. And those are illegal vape pods. And you can find them in every school. And every school, there's always going to be one kid. In Asheville, Alabama, last year, I was going to do a program for the high school, and the principal came up to me and he said, we just took $90 off of a middle school kid. It was early in the morning. He'd already sold $90 worth of vape pods that morning, see? And that's how big a problem it is, because it's really good money in this. But it got up to 70 deaths and about 4,000 hospitalizations, and then it stopped. And you know why it stopped? It didn't stop, but something happened in this country where people started having severe lung disease. And what was that? COVID. And then all of a sudden, you didn't hear about EVALI anymore, because they'd go to the hospital, and if you died from a lung disease, what did the hospitals, for the most part, what did they say it was? Somebody actually, and I don't believe this, but somebody said the hospitals actually got more money if they turned it COVID. But I didn't know hospitals made money on like that anyway, but hey, but this is what I want y'all to know. And the concern that we have for everybody. Vape pods and marijuana and candies, they all have fentanyl in them now. And we're seeing it all across the board, the damage. But if you get your hands on a vape pod with fentanyl in it, See, I have to tell y'all, if people don't know, all it takes is 2 milligrams of fentanyl to kill you. 2 milligrams. A teaspoon holds 4167, and 2 milligrams will kill somebody. This, can you imagine the power of something that would pierce a piece of metal through the teeth when it blew up? Real quick, because the dean has told me y'all are leaving here at 4 o'clock. With or without that TV. And I know where one of them's in the back of my truck. Disguised vapes real quick. You can order the cases right off Amazon. Pens, Sharpies, watches. This is interesting to me right here. That is $75 lipstick. And my wife said, so? And I said, that doesn't sound like a lot. She goes, well, I guess it depends on what kind of lipstick. I said, if I find out you've been paying $75 for lipstick, you're going to need a double roll of it. $75. That's 5 days worth of work for me, y'all. I'm going to finish up with the edibles, and unless I got time to, because I don't think I heard a couple people mention Trank, and I want y'all to know just a little bit about it. The edibles, real quick. When they first, back 2016, 2017, I remember there was an article that came out that said medical marijuana was moving forward in Alabama, and I remember being shocked, because the Surgeon General at the time said there's no such thing as medical marijuana. This is an Alpha magazine. They put out to the people that pay for their insurance, they put out quarterlies. And I saw this and I just thought how ironic it was that the very people that have the most to lose, because when you're under the influence of alcohol or marijuana, you're way more likely to be involved in a wreck. That makes sense, right? So the very people that have the most financially, besides the kids that are getting killed and the parents of the kids getting killed, are the insurance companies. And they put this in their quarterly. And I actually asked a man that worked for them that was high up, I said, why did you do that? And he said, it was just, we did it lightheartedly. And I said, I'm going to tell you something. I don't take messing with kids lighthearted. See, this whole thing about the marijuana movement and all, when they say, well, it's just hemp. It's not just hemp, y'all. We are living in a time where Delta 8, Delta 9, Delta 10, Delta 11, THCO, Delta 5, all of those components are synthetic drugs. In fact, only 0.5% can you derive from the hemp plant. They take the rest, like Robin said, they take CBD and they go through a synthetic drug process called isomerization, and they convert it into the deltas. And because 0.5% you can get the Delta 8, they say, well, the rest of it is legal too. My math is not great, but I'm just telling y'all, we have had more overdoses this year. Last week in Talladega County alone, 2 overdoses from a new drug called HHC, which is in the same family. But then the former FDA boss came out and said, actually, you can't put CBD in anything that's food. Now let me ask you, what are gummies? What are the energy drinks? Why are they not enforcing? Why are they not cleaning up their own house on this? CBD gummies, Clay County, 3 Clay County kids hospitalized. They ate these that they bought in Wadley, Alabama, in Randolph County. All 3 of them went to the hospital. We sent it to the lab, and we asked for a rush job, and we got it back 2 years later. Honestly, honest to God, I promise you. But the results is highlighted. It did have a little CBD in it, but it actually had a controlled substance, AB Pinaka, in the gummies that is sold in convenience stores. The point I'm trying to make to everybody, and everybody should be very concerned with this, there's no oversight, and they're getting by with murder because they know our lab does not do quantitative testing, because the Farm Bill says you can have up to 0.3% THC. This stuff is way over. And that had a controlled substance in it.
Autumn Richards is a happy 10th grader at Bartram Trails High School, but all of that changed last Thursday. Richards thought another classmate gave her sweet gummy candy. Instead, he gave her gummy laced with drugs.
Autumn.